a funny kind of feeling. No one leaves behind the door. I guess I'm gonna keep on moving. Ain't gonna be back no more. Driving me crazy. If I didn't know any better, I think you're driving me mad. You can make trouble, but I'll be damned if you make me sad.
Test your microphone.
If you make me sad, I'm not sticking around. Sugar-coated heartache. I'm not hanging around in case you change your way. You can make trouble, but I'll be damned if you make me stay. Don't try to make me stay. You're gonna make me stay. mile in my shoes, then you know how I feel. Wore my shoes for you judge this man. If you walk in my shoes, you might understand. Now I'm a simple type of fellow. I don't need much in this old life. I read my Bible, Lord have mercy. I try to live my life right. I don't need nobody. Tell me what I ought to do. 'Cause if you really want to help me, just take a walk in my shoes. Walk a mile in my shoes, then you know how I feel. Walk a mile in my shoes, for you judge this man. If you walk in my shoes, you might understand. Mr. Roberto Mobioli, y'all. Yes, sir. Now don't mile in my shoes, walk a mile in, walk a mile in my shoes, walk a mile, walk a mile in my shoes, walk a mile. Hey, now walk, for you judge this man. Walk a mile. Now walk, if you walk in my shoes, walk a mile. Oh, people, you might understand. Walk a mile. Walk a mile in my shoes. my shoes. Yeah, now walk a mile in my shoes. For you judge, this man. If you walk in my shoes, oh people, you might understand. Walking by you might know how I feel. Oh, people, walk a mile. For you judge this man. If you walk in my shoes, well, you might understand. Walk in my, you walk in my, walk in my, walk in my, you walk a country mile. Walk in my, you might know how I feel. You might understand. Walk a mile. Walk a country mile. You might know how I feel. You might understand.
It's been so long, so very long, since I've been loving you. You went away, away and left me so alone.
Good morning, everyone. We are about beginning our program. Good morning, distinguished ladies and gentlemen. We are very excited to have you join to be your experience. So to kickstart this program, we would like to call on the Director of Nursing, Mrs. Ozioko, to lead us in opening prayer. Thank you. The Director of Nursing.
Shall we pray? Please, let's give reverence to God. In Jesus' name we pray. Almighty and everlasting King of glory, Father, we come before thee this morning in adoration and praise and thanksgiving, O Lord, for your goodness unto our lives. We thank you for the gift of life. We thank you for your divine provision, your protection and safety over us and our loved ones and our patients. We thank you, O Lord, for a day like this. Father, we have gathered for a purpose, and that purpose we commit unto your hands, O Lord, praying, Almighty God, that you come and be with us from the beginning to the end. Guide us and lead us aright in all our deliberation, in all our prayers. Those that are yet to, on their way coming from our course, and lead us safely back to our various destinations. In Jesus' mighty name we pray.
Thank you very much, Ma, for that opening prayer. As customary with programs of this magnitude, it's important we honor our country, and so we will all be standing up to sing the national anthem, and leading us in that is Dr. Frank.
Nigeria may be blessed. Arise, Yaba psychiatrist, let make Yaba great in our time. Let promote good health services to meet the changing public needs. Yaba must be great in our time. Lift high Habana of great wealth. Good mental health a priority. Best service to humanity. To make Yaba great in our time. Lesion of forms of corruption. Let prioritize patient welfare above our own convenience. Let others be driven by the fear of God in all we do. Let's support all our leaders and leave their hands up all the time. Let's remember funding petrol to make Yaba great in their time. Those who gave their best, they were here. And let great legacies behind. Let us contribute our
Conference. And the theme of this conference, like we're all aware, is research, clinical practice, and training, staying afloat amid dwindling resources, with the sub-theme mental resources, with the sub-theme mental disorders across the lifespan beyond clinical presentations. As we are all aware, research and quality data is one of the pillars of healthcare strengthening. As health professionals, our practices are supposed to be guided by time-tested that has been done, in addition to our clinical expertise and experiences. One of the things research fairs like this affords us is the opportunity to stay abreast with relevant and time-sensitive advances in our clinical practices. And so through the program, we'll be listening to researchers who have put in painstaking work to come up with studies that we believe will affect the way we practice. So we'll be recognizing distinguished ladies and gentlemen.
So, we're privileged already to have our guest speaker room, and they came with distinguished set of people also. I want to recognize them on this auspicious morning. We have with us our guest speaker in the person of Professor Moruf Adelekon. Please a round of applause. Hospital Yaba. And it's the Ba Ashegun of Ba Ashegun of Ba Ashegun of Ibadan land. He's also the Sile Toko. I've disappointed my Ibadan people. I'm really sorry. I'm really sorry for that.
Repeat it.
The Bashegun of
Bashorun.
Bashegun of Ibadan. Thank you very much. And he's the chairman of today's research fair. He's no other person. Okay. Sir R.E. Ladapo. Please, a round of applause for him, sir. When you see him come forward, you will see how he's looking in his regalia. Very handsome, and like my generation would like to put it, demure, elderly man. Good to see you, sir. Thank you very much, sir, for gracing our occasion. It's a privilege, and it's good to be back home. Can we greet him in our language?
He's a very good friend, a barrister all the way from the United Kingdom, Mr. Jolayemi Barrister.
Hey, don't you will have.
We
Okay, so still recognizing our distinguished guests, we would like to warmly recognize the Director of Administration, a man of proven capacity.
So, while we are still waiting for the medical directors to give his welcome address, I just want to recognize all other. I just want to recognize a couple of other consult. The MD is very much with us already, and I want to notify you that this program is an hybrid event. It's both happening in real time and virtually. And in the virtual room, the MD is already much present, as well as other guests. So without much ado, we want to welcome the medical director of the Federal Neuropsychiatry Hospital Yaba, who is also the chief host of today's event, and the person of Dr. Olugbenga Owoye. A round of applause for him. And the medical director will be giving his goodwill message and his welcome address. Thank you very much.
Am I audible enough?
Yes, sir. We can hear you, sir.
Am I audible enough?
Yes, sir.
Good.
We
Good
can
morning.
hear you, sir.
Okay. Good morning, everyone. I want to really start by apologizing for my absence physically because of the exigency of the duty. Currently, I'm on a ministerial retreat on performance management system, which is replacing our regular APA. You can't do it by proxy. So you have to be there. So the program has been on today and is going to end tomorrow. So please kindly bear with me for my absence. Be that as it may, I want to recognize this morning our chairman, my teacher, my mentor, our home dear Bashorumba Segun of Ibadan and worldwide, Dr. H.T.O. Ladapo. I really appreciate you for coming. We thank you for being there for us. I also want to recognize my mentor, my teacher, who has been in great support in this assignment, our past medical director, Dr. Cecilia Oluwayemi Ogun. Thank you so much. We thank you for being with us on this, for your support and for honoring our invitation. Professor Malup has been a teacher long while, right from medical school. I remember when he examined me in medical school, and he said, "You are doing well. You are likely to become a psychiatrist." I also want to recognize, starting with my Dr. Adenika Antwi, and the head of nursing services, Mrs. Ozioko, the director of finance and account, Mr. Omalolu Makinde, and the director of pharmaceutical services, Mr. Ajayi. We really appreciate you so much this morning. And our own secretary for the TMC, Mrs. Ikejiaku. Thank you so much for being here today. Also, I would like to recognize the count here, Dr. All the various cadres of consultants in the house. I just want to say big thank you for your support, for making this year research fair big and better. So we really thank you so much for your support and for your dedication to duties. I also want to recognize all the head of department in the house. I may not be able to mention your name one by one, but I just want to say I appreciate you for your contribution to the advancement of the hospital. I also want to say a big thank you to all the members of staff of Federal Neuropsychiatric Hospital, Yaba, Lagos, particularly all the directors, the deputy directors, the assistant directors, and the various cadres of staff. I say big thank you for your renewed hope and commitment to the Yaba project. Thank you so much. Our own distinguished guest from United Kingdom, Barrister Jolayemi Olaofe, we say big thank you for being all the faculty members of the Yaba and recognize, I want to recognize especially this morning, General Fulate, who has been with us all this while, and is still with us up to this moment. Dr. It's with great pleasure that I welcome you to the 7th edition of Federal Neuropsychiatric Clinical Practice. This theme could not be more apt, given the prevailing socio-economic situation in the country. The downturn in the economy has definitely adversely affected virtually every aspect of mental health, including funding for research conditions. To mention for few, this is of the quality of mental health research and socioeconomic factors and improvement in socioeconomic indices with enhanced mental health of the populace. They are known to have better socioeconomic indices and more improved mental health status than most countries in the world. Ladies and gentlemen, mental health care for most Nigerians and restricted treatment options for the poor. It is therefore important to in ameliorating these conditions so as to improve the mental health status of the population and reduce the prevalence of mental health disorders to the barest minimum. This year and discuss today. Once again, I welcome you all and thank God 7th and a fruitful deliberation in today's program. Thank you.
Thank you, the medical director. for that welcome address. So we would like to once again thank each and every one of us who have made it. So thank you each and every one of us who have made our time to be present for this 7th edition of our annual research. Viewers who are with us, thank you so much. So moving on in our program, we'll be receiving goodwill messages from distinguished individuals. So we'll be receiving goodwill messages from distinguished individuals, beginning with the chairman of the occasion,
Akinola, as mentioned, and also our colleagues in the statistics. Dr. Folabo, I cannot say without you. HODs of pharmacy, accounts, and everywhere. My friends too, nurses, HOD nursing, and other nursing cadre that are present here. The organizers, I recognize you, Dr. Majid Bello, who has been following me with telephone calls that I should be here today, promptly at 9 o'clock. I thank you very much for being prompt and meticulous with your job. Now, I'm Sir Harry Ladakbo. I retired here 14 years ago as a medical director, and I'm happy to see the goodness of life here in Yaba again. Everybody's shining and looking good. And also at the same time, it's always very good to see progress and hope renewal, as the President of Nigeria said, hope renewal. When I saw Dr. Olufolabo, it reminds me of many years ago now, when we first met and we were planning about this research program with late Dr. Malomo of blessed memory, and late Ms. Jinadu, who was in charge of psychology department then. We thank God today that it has blossomed. Many of you have become professors all over the world. I traveled to Australia, I met Yaba doctors there, consultants. I was in Canada, I saw a lot of them, they entertained me. Even in the UK and in New Jersey, I saw a lot of them. Because I've traveled so much, and I thank God for the privilege I had in the training in Yaba here. I'm a Yaba boy. Are you listening to me carefully? Yes, I did my youth corps here in 1980. And we are still relevant, I believe. We are still relevant. Because if you are not relevant, you will not be able to invite us here today. In good health, you will be relevant. You will live in prosperity in life. And when you retire, you will retire very well. Don't see government money. There's no need for it. Are you listening to me? Work hard. Be skillful. When you're a doctor, learn some skills apart from your medicine. Some skills apart from your medicine. I used to lecture with General Okulate. He was a very good friend of mine. He's still Okulate. He was a very good friend of mine. He's still a very good friend of mine. He's in UK. I'm going to see him in Christmas in UK. Yes. I remember in 1986, he was doing his part 2 in Yaba here at Oshodi on dementia. Are you listening to me? This actually in 1986. 76, I think. 86, yes, 86. You are also 86, I think. Are you? 87, yes, I remember. O'Hari also is 86, and Udofia. You know, so we've come a long way. May God continue to bless all of us. Do research. I was talking to Barrister here about the essence of research concerning the program, today's program. You know, is the consequences of research is what we need in Nigeria to move forward. We are blaming the government that there's no money, there's poverty, there is this, there is that. Yes, there will always be poverty in any society. But Nigeria is great. I don't know if there is poverty in the country. Yes, in this statistics will tell you about that. But inside of you, if you have the mentality that you are poor, you will remain poor. But if you have the mentality that even as a poor man, you are rich, in Jesus Christ you'll be rich. and glorious. That is the Bible now. So as we are going to have this program, I want you to enjoy this program. Jot down points as how you can assist the nation, because the topic actually centers on how do you do it, research in a dwindling economy. There's no money in the country. They say yes, but we are buying private jets. There's no money in the country. Americans are coming here, changing dollars into naira and making so much money. Country in old age. When you talk about Sir Harry Ladapo, a knight of St. Christopher. If I don't deserve it, if I don't deserve the Olubadan will not give me Bashorun Bashegun. The Olubadan will not give me Bashorun Bashegun. And that is the truth. I did not buy it. I did not pay for it. Honor should be bestowed on you. And that's what I'm talking about. Skills. We don't beg for anything. I don't beg. But God will provide for you. He will send favors. Dr. Lekon, Professor Lekon, as you are coming today to give lectures today, you know, psychiatry is a funny profession. And psychiatrists themselves are funny. You see, I remember my professors. Professor, the man from Benin, Professor Ayo Biniti. You know, he was a philosopher. They will go down to the nitty-gritty of psychiatry. And that is mental health, social psychiatry, environmental psychiatry, and so on and so forth. And social marketing. Every psychiatrist must market himself. I knew Professor Adigbabu when I was at Lagoon Hospital. That's the father of Professor Shodi. We became friends. I consulted at Lagoon for about 30 years. Yes. Till they closed down in Apapa. And it is marketing when I was consulting with Professor Adio Lambo at Lambo Clinic in Isaac John. Mrs. Fernandez, Mama Fernandez, she was my matron. Yes, she's alive now. I'm always very proud of Fernandez. I don't know why I was not invited today. Because sometimes people don't know history about Yaba. And that's why the librarians should always be around. That the man who brought me to Yaba here was Fernandez. He drove me in his car. He was an assistant secretary and head of the admin. I don't know whether there exist people with humility like that today amongst my colleagues here. He was so humble. I came around as a young man in suit. I wanted to do a youth call in Yaba here. And I said, I don't know the office of the NYC in Lagos. He said, oh, let's get in my car. That's how he took me to Animal Sham. And I was in charge, also Fernandez. So I got my letter. Within hours, I came to Dr. Johnson here. And I was giving accommodation, 3-bedroom flats. Can you imagine me in Lagos with 3-bedroom flats and a Volkswagen? That was 1980 for you. I wish we still have good people and nice people, God-fearing people that can still continue to sustain the nation. I beg you, and God bless you as you come today. Thank you very much. As the chairman of the occasion, let me advise you. I'm very, very tolerant. I want to learn more about new things in mental health. Thank you.
Okay. It's also It's also not online. Okay. Thank you. In a Rolls Royce.
Who would that be?
Of course, it was a systematic review that arrived in a Rolls Royce, and the other review that arrived in a Rolls Royce, and the others were like, you know now, case control, the courts, the case study was like, gosh, I wish I was this guy. Then while RCT and systematic review were bragging with their cars and with all their protocol, the air traffic controller started telling everybody to leave way, and someone else is coming. Of course, systematic review girl, who could be coming after me? You get, and everybody were amused. Who was coming? a Bombardier air jet was just flying in and cruising from the altitude, trying to land. And like, who could this be? Of course, systematic review have arrived now. Who could be bigger than systematic review? To the shock of everybody, guess who arrived? To the shock of everybody, guess who arrived? A cross-sectional study. And everyone was shocked. Ow! Ow! No! This is unacceptable. So when people were chasing relevance and money, I went for the numbers. And I have a lot of people behind me. So I was able to get my money from the numbers. And so the morals of that was that it's just to opine the topic we are discussing today, last research, clinical practice and training, staying afloat amidst dwindling resources. Of course, the world is moving towards experimental and even biological researches, and it's in committee for making that possible. And so we'll be going in committee for making that possible. And so we'll be going into that right away.
Please, before we go on for the breakout session, we really want to appreciate our teachers, our trainers online, Professor Uwakwe, General Okulate, Dr. Adebowale, Dr. Ijarogbe, Professor Sheikh Latif, Professor Tunde Ayimode, Dr. Mustapha Sanbe, Dr. Niran Okewole, Dr. Tolulope Bella, Professor Omigbodu, the President of the Association of Psychiatrists, Professor Taiwo Obindo. We were meant to have a short goodwill message from the President Association of Psychiatrists. I don't know if Professor Taiwo Obindo wants to give us a short goodwill message before we break out for this session. Professor Taiwo Obindo, sir.
Okay, so we received the goodwill message from Professor Taiwo Obindo. Okay, then so we'll take these good messages after the breakout session. So for the modalities for the breakout session, the following research topics will be done here in the conference hall: surviving as a researcher in poor resource settings, the case of psychiatrists in Nigeria, preparedness of medical students towards postgraduate medical education, a cross-sectional survey, sleep disturbance, social support and functioning in patients with bipolar disorder in a Nigerian hospital, prevalence and correlates of aggression in acute care wards of the Nigerian psychiatric hospital, cognitive insight and its role as a predictor of relapse among persons with diagnosed mental and behavioral disorder at Federal Neuropsychiatric Hospital, Yaba, Lagos.
Okay. Well, the following will be held at the Total Diagnostic Center: prevalence, pattern and correlates of substance use disorder in patients with schizophrenia, emerging trends, body mass index of Amal-Jiri pupils in northwest Nigeria, a call for intervention, optimism and its correlates among outpatients with major depressive disorder in a mental health facility in West Africa. And we'll also be having a pilot validation of the DSM-5 substance use disorder checklist among Nigerians. And then finally, we'll be having the Association of Opioid Use Disorder and healthcare utilization among patients with sickle cell disease in northwestern Nigeria. So those sessions will be held at the TDC building, while the earlier read out sessions will be held at this center. And so we would like us to, I don't know the modality for the separation.
Okay, Professor we're able to get Professor Taiwo is unmuted currently. Just Professor Taiwo Obimdo. Good morning, sir. Good morning, sir.
Good morning.
Hello. We heard you briefly,
Around.
sir.
Let me start by aligning myself with the protocol. I start with the chairman, the bar schedule, the CMD, all my teachers and mentors and the colleagues that are available. It is yet another time together to share ideas, but the major limiting factors remain the dwindling economy. I always say that for us to work in the hospital setting, we have 3 areas we need to look at. Our clinical sessions, teaching, training, as well as research. And we need to make sure that the 3 go hand in hand. Yaba has given us another opportunity to discuss this. With the dwindling economy, with the dwindling challenges, as Shegun said, nobody is poor in Nigeria. But I'm sure research will tell us how many poor we have, because we actually look at it as a multidimensional, not even the regular poverty that we know. And we know the relationship between psychosocial factors and then the mental health conditions. So it is an opportunity for us to look at things again and to come up with the right indices so that the world will know. So on behalf of the Association of Psychiatrists in Nigeria, I welcome you to this 7th edition, and I hope that we will be more enlightened and then we will be more focused subsequently. I congratulate Yaba and I say all the best to all of us. Thank you very much.
Thank you very much, sir, for that very brief and succinct speech. We'll need the ushers to help us with those who will be going to the TDC, to help us to give our guests a. The TDC is just downstairs by the left from when you're leaving from this conference hall. So I'm sure we have ushers at the entrance waiting to direct us towards the TDC. So for those who have their research papers number 1 to 5 on the right of the program, we'll be meeting at TDC, and our panel at the TDC include Dr. Stephen Oluwane, Professor Yewande Oshodi, Dr. Sunday Amosun, and Dr. Olusegun Olufolabo, while the panelists here in the conference hall are Dr. Oluwayemi Ogun, Dr. Olafumlaye Akinola, Professor Olayinka Tilola, and Dr. Yesiru Karim.
So Dr. Yesiru Abdikarim will join the panel B at the TDC, and Dr. Olufolabo will please join the A here in this hall. Yes, slight arrangement. Thank you, sir. Please, as we remember that the guest speakers lecture will come up immediately after the paper presentations. So we'll come back to the hall here for the guest lecture. You can't afford to miss it. So remember. Thank you.
So welcome to this first breakout session. So, and time is of the essence. We are already running behind schedule. So, we would want all participants presenting to be very much alert. We'll be called in the order that's been put on the program. So, first, a word from the panelists. So we're going straight to the presentation, and we are delighted to have our panelists for this breakout session around. Dr. Ogunya, once again, welcome, ma. Dr. Akinyola, you're once again welcome, ma. And Dr. Olufolabo, you're once again welcome, sir. So we're just getting a word from you prior to the presentation of the panelists. From each of you. Oh, okay, then. Okay.
Good morning, everybody. I hope all our presenters are here. So we're going to start immediately. You are given 7 minutes each, and you are going to be, the criteria for marking is your statement scoring, statement of problem and justification for your research, the study design and methods, data analysis and and conclusion, presentation, organization, coherence, and use of virtual aids. Then oration, audience, eye contact, and your presence. So those are the things we're going to look at. So I think, moderator, sir. So the first presenter should come.
Thank you very much. Without much ado, I'll be inviting the first presenter for this breakout session, Surviving as a Researcher in Poor Resource Settings, the Case of Psychiatrists in Nigeria. Please, the presenter should kindly come forward. Thank you very much. Okay, it's online. Okay.
I'm presenting online, please.
Okay. Okay, sir.
Hello?
Yes, sir. We are with you, sir. You can go ahead, sir. The floor is yours.
Hospital Yaba, especially the patients they gave me to submit that late. I'm holed up. I'm actually in Shagam. All of you know what we are suffering in the southeast. Very briefly, can you go to the next slide? Because I'm on the way. I'm actually in a car for problems. So I'm not able to move anything by myself. Look at the title. I borrowed this from the team of the program. Surviving as a researcher in a poor resource setting, especially the case of psychiatrists. And we gave thought to the problems we are passing through at the moment, especially the issue of brain drain among health workers and generality of Nigerians. And those who have chosen to stay back in the country amidst inflations, changes in petrol price and all that. And nobody seems to be certain of the next moment. So our major aim here is, does it really benefit anybody to stay back in Nigeria to continue to practice psychiatry? And more importantly, what about that research? What about that research? Looking at the context we currently are in, is it possible for us as psychiatrists to continue to survive as researchers in the present system? And what advantages may we derive if we decide to stay back in the country and continue to engage in psychiatric research to make our contributions? So what did we do? This was a narrative review. So we looked at publications or papers, narrative literature, looked at case studies. We are all familiar with the push and the pull factors of brain drain. And then we considered the advantages and disadvantages of leaving the country to practice psychiatry outside the shores of the land, and what effect this may have in psychiatric research within our own setting. What did we find? Because I'm not even able, I'm just talking to the slide from hand. As I said, I'm in a very awkward place, actually in a car, hold up at Shagam. So what did we find? As we said at the beginning, by way of introduction, there is massive drift of psychiatrists within the country, by oral interviews, by literature review, and so on and so forth. You can hear somebody talking where we are. But I was so much attached to Dr. Adioye because of the huge resources spent in establishing what could have been our only functional sleep laboratory in the country. I wept when I came and it was that Adioye had left. All my very good friends. So this is what we found. This huge brain drain and the effects it is having. Because those who have chosen to remain in the country may likely focus on trying to survive only economically rather than giving attention to psychiatric research. But as we said, psychiatric research is the cornerstone of the practice itself. I think the president of APM mentioned it. But everything we have today, from Bleuler to Kraepelin to Sigmund Freud, without research in psychiatry, we would not be where we are today. So it is the foundation of our practice. It is the foundation of our service. It is true that people may have reasons. People may have their personal reasons. Very a problem. Hello? Hello?
Hello, Prof.
Hello?
Hello, Prof. You can continue. Although we have 2 more minutes
Hello?
more of your time. Hello? Hello,
Hello?
sir. Hello?
Hello?
Hello, sir.
Hello? Hello?
Can you hear us, sir?
Oh, no. Hello?
I think we have a network glitch here. Okay. Sir, I think we have a network glitch on your hand, sir.
Because I'm using my phone, as I said, I'm in a very awkward place, and the people are calling me on phone.
Okay,
Let
sir.
me try to conclude by saying that migration is purely personal. Individuals will have to decide. But you have to consider a number of factors. Number one, it is possible to survive. A call has interrupted again. Hello? Oh, this is shameful. Hello?
Please go on, we can hear you. Go on, sir.
Of course, we are coming and they disrupt and say, let me summarize in 2 or 3 sentences because of the awkward situation. That people can survive and they make contributions to psychiatric research if they prioritize very well And it is an opportunity. In fact, the situation we face in the country has presented us with an opportunity. There are many areas gaping for us to investigate, including the foundation of what has made us where we are today. We can collaborate both with our colleagues in diaspora and within the country and the West African sub-region. And let us not forget that at the end of the day, we need to consider the ethical issues with respect to leaving the country. And on that note, I want to congratulate the Psychiatric Hospital Yaba on their continuous exercise in building human capacity, in maintaining service, and very importantly, taking this key role of organizing research meetings so that we can meet the demands of society in future. Thank you very much for your time.
Thank you very much, sir.
Thank you very much, sir. Thank you very much, sir.
That was so. We'll move on to the next presentation because of time. Just a reminder: each presenter has 7 minutes. 2 minutes to the end of the presentation, you'll be given a prompter for those who are here physically and even online. You'll be sent a private message as a prompter. For those presenting online, please endeavor for our audience online, endeavor to mute your devices, and those presenting should endeavor to also put their devices in airplane mode to avoid infringements on the network. Thank you very much. So we'll move to the next. We'll move to the next presenter. We'll be talking about preparedness of medical students towards postgraduate medical education. A cross-sectional survey. Is that presenter also online? So please, can presenter come forward, please? Thank you very much. A round of applause for her, please.
Good morning, fellow colleagues, distinguished guests, and fellow researchers. My name is Odemono Damilola Kudrat, and I'm a final year medical student of Olabisi Onabanjo University, Shagam, Ogun State, Nigeria. In addition to my education and academic journey, I have been to carry out some programs, being that I am also an official of the Federation of African Medical Students of Africa, because as a final year medical student that I am, I understand the challenges and difficulties in navigating the career pathways and postgraduate medical educations that is faced with Nigerian medical students. So, as a federation, as a member and as a council member of the Federation of African Medical Students, I was opportune to organize a program which caters for medical career pathways, mentorship as one of the objectives. So, through that experience, I was able to understand and also have a first-hand experience and observe what these students go through. So we had this program earlier this year, and we were thrilled, and so many people actually had guidance to their career pathway just through that program that we had earlier this year. So, and I would also like to say thank you very much for allowing me to present here, because the theme of this conference, it aligns with my research title, which says preparedness of medical students towards postgraduate medical education, which is a cross-sectional study. Next slide, please. All right, I'll be going through those outlines. So, starting with the introduction. As I said earlier, transiting into the postgraduate medical education is something that is a dilemma for most medical students. They don't know which way to turn to, especially even to our amazement, even so-called clinical students who have undergone all the necessary medical and surgical rotation still have the same issues. Likewise, the non-clinical medical student as well. I'm talking about from 100 level to 400 level or 300 level. They still have the same difficulties in which the clinical students from 400 level to 600 level are still having, despite going through all these rotations and clinical experiences. So this actually made me this fueled my interest in going through this research and carrying out this study. So as we can see from here, that the National Postgraduate Medical College of Nigeria, along with the Medical and Dental Council of Nigeria, that's the MDCN, they currently have 16 postgraduate medical faculties, and these are the list. Please go to the next slide. Yeah. So these are the list of the faculties that they have. Next slide, please. So going to the aim of this study, it's not something that is obscure. So the aim is that we want to examine the readiness of postgraduate medical education among clinical medical students in 4 Nigerian universities. And the spotlight of this our study involves to measure the level of awareness and preparedness, and also the factors influencing the participants and the respondents' choice of specialties. And we also want to know the gap that is present in our present educational system that is influencing all of these difficulties and challenges faced by medical students. Next slide, please. All right, the methodology. Next to the methodology now. So the methods, as we can see from this slide, the four medical schools that were examined, that were involved in this study, are listed here. Next slide, please. So this cross-sectional survey, it involves 150 medical students, majorly the clinical medical students. And when I say clinical, I mean from 400 level to 600 level. That's the final year. So we noticed, and we did it in 4 institutions, as I've earlier said. We did in University of Ibadan, University of Ilorin, Lagos State University, and Obafemi Awolowo College of Health Sciences, which is Olabisi Onabanjo University. And then we actually used a questionnaire, which is a semi-structured questionnaire, and it was adopted from the American Institute for Research in the Behavioral Sciences of Medical School Graduation and other previous studies. So, and we also add some modifications to it so as to go in line with our aim and title of our research paper. All right. So the questionnaires focused majorly on these 6 sections. One is the basic demography, followed by the interests of the medical students, mentorship and motivation, continuous seminar programs, perceived gaps and challenges, solutions, and way forward. And after collection of this data from the medical students, we used a web-based questionnaire. So after collection of this, we were able to clean the data and analyze using statistical tool Excel 2021. So that was what we used. So as you can see, that was what we used. So the result was actually something we actually let me say predicted, so to say. We were able to use the sampling method we used because we did not have so many people interested in the research as much, and because of the inclusion criteria, some people did not give the consent and all of that, so we just had to limit it. And as we can see from the results section, the mean age, that is the average age, was 24 years. And as we can also see right here, we can see that most of the respondents are from year 4. Next slide, please. And the specialty of choice was most of the respondents, they surgery as their specialty of choice. And also psychiatry was one of the top 5 specialty of choice for was one of the specialty of choice, which means that specialty is gaining, psychiatry is gaining fame and popularity among medical students as opposed to the way it was previously in those days. Next slide, please. So most of these respondents, passion was the main factor influencing their choice of specialty, while remuneration was also one of them. Please, next slide. So as we can see that mentorship, this is the section for mentorship to assess if these students actually have mentorship opportunities in their different schools. We can see that there is a low mentorship opportunities in their various institutions. Next slide. Next slide, please. All right. So the level of understanding majorly was very, very low. Despite the fact that they are very interested in pursuing postgraduate medical education, but the level of understanding was still very low, drastically low. Next slide, please. Next slide. So the strengths and limitations for this research is that the strength is that it is multi-centered. It is not just focused on one university, but multiple universities. So it's actually evidence-based. And the limitation is that the sample size, they were not equal. Like in some schools, we had more respondents than some other universities. Next slide, please.
Please, you have to conclude.
All right, thank you. So in conclusion, so the study concludes that there is a low level of understanding and preparedness of medical students to develop their interest in pursuing postgraduate medical education. Thank you very much.
Thank you. Please, a round of applause for her, please. That was quite courageous. Thank you very much. You can have your seat. That was quite courageous. Please, a round of applause for her once again. Thank you. For the next presentation will be sleep disturbances, social support, and functioning in patients with bipolar disorder in a Nigerian hospital. Please, let's keep to the time. It's 7 minutes. We'll be giving a notification at 2 minutes to go and at final presentation. You can come forward, sir. Thank you.
Good morning, my teachers, colleague, and distinguished panelists. So I'm Dr. Salawa Abiola Mukhtar, a senior registrar in this hospital, and I'll be taking this presentation for the affective research disorder group. So the research title is Sleep Disturbance, Social Support, and Functioning in Patients with Bipolar Disorder at a Tertiary Mental Health Hospital in Lagos. So as a way of introduction, mood disorders are psychological illness that affect emotions and behavior. And prominent among mood disorder is the bipolar affective disorder. And as you can see clearly that bipolar affective disorder contributes 7% of disability-adjusted life here due to mental disorder, and it affects 2.4% of the global population. Okay, so bipolar is a lifelong, which means it's chronic and high episode of frequency, it relapses, and is also associated with a poor functional outcome. This is according to Calvero et al. In 2020. And sleep disturbance, social support, and functioning are interconnected aspects in patients with bipolar disorder. So sleep disturbance is important symptoms in patients with bipolar, as it has been suggested by Gruber et al. That sleep that are shorter than less than 6 hours and those longer than greater than 9 hours can impair patient functioning and quality of life. So most patients with bipolar disorder, irrespective of the phase of their illness, they have significant sleep disturbance. And sleep disturbance can be an early indicator of imminent relapse. And about as low as 15 and as high as 100% of patients with bipolar, even in their euthymic phase, can experience sleep disturbance. So studies have shown that about a third of bipolar disorder patients has problem with their circadian rhythm, sleep-wake cycle, and many studies have actually associated sleep disturbance with functioning in patients with bipolar disorder. Okay, moving on to our other variable, which is social support. It plays an important role in the management of bipolar disorder. And then support could either be structural in terms of people that are available, and it can be functional in terms of the resources that are available, financial or material resources. And the level of social support affects the course of the illness in terms of relapse and in terms of recovery. Okay, so we know that functioning is an important treatment outcome in patients with bipolar disorder, and very few studies have actually looked at functioning, an associated factor in our country. So the essence of our research is to look at functioning and look at important correlates like social support, sleep quality, and also look at social demographic variables that are associated with functioning. As we all know that this is going to improve the holistic care of the patient. So moving on to our aim and objectives. So our aim in this study is to assess the relationship between sleep disturbance, social support, and functioning in patients with bipolar disorder. And our specific objective are: one, to determine the social demographic factors that are associated with functioning, and also to determine the association between social support and functioning in patients with bipolar disorder, and to determine the association between sleep disturbance and functioning in patients with bipolar disorder. So moving on to our methodology, this study took place at the Federal Neuropsychiatry Hospital, Yaba, at the General Adult Outpatient Clinic. And the duration of this study was from 1st of July to 31st of August in the year 2024. The study design is a cross-sectional analytic study design, and the inclusion criteria were patients that were within age 18 to 24 years, and those that made ICD-10 diagnosis of bipolar affective disorder, and they've received treatment for at least 6 months. They've received treatment for at least 6 months, and we've gotten an informed consent. Then the exclusion criteria were patients with acute behavioral disturbances and refusal to give consent. So moving on to sample size. So according to the hospital record, we're able to calculate our sample size using the prevalence of bipolar disorder to be 14%, and the total sample size we got using the Kish formula was 186. So the sampling technique that was used in this study was consecutive sampling technique. As patients came into the clinic and they made the inclusion criteria, we recruited them for the studies. So moving on straight to the instrument. So the instrument we used was one, we used the social demographic questionnaire. We did a mini international neuropsychiatry interview to confirm the diagnosis of bipolar affective disorder. Then we also used the CGI, Clinical Global Impression Scale, to measure the severity of illness, and the 3-item Oslo Social Support Scale. Then we also used the Pittsburgh Sleep Quality Index, the 19-item, and the Global Assessment on Function to assess patient functioning. So the procedure of this design of this study was straightforward. When patients came in, those that made the diagnosis of bipolar were spoken to, and informed consent was obtained. Then the questionnaire were administered. So going to ethical consideration, we got an ethical approval from the Ethical Committee of Federal Neuropsychiatry Hospital, Yaba. Then data analysis. So it's important we state here that our independent variables were the social demographic variables, the 3-item, the score of 3-item Oslo Social Support Scale, and the Pittsburgh Sleep Quality Index. While our dependent variable was the Global Assessment of Functioning score. So data were analyzed using the SPSS version, and the mean median were used, and also the level of significance is important, was set at 0.05. So moving on to our results, so moving on to the results. So this is the social demographic characteristic, the table 1. So it's a bit not too clear here. So it's important to just point some few important things that majority of our patients were between 20 to 29 years. And so we also have a table. The second table was table 2, social demographic variable and the association with functioning. So it's important to state here that the age, looking at the p-value, the age was statistically significantly associated with functioning. Then our third table, which is the table 3, is showing the Pittsburgh Sleep Quality Index and functioning. And we can see that the p-value was 0.001, which is less than the level at 0.05, which was set for significant. Then moving on to correlation. So we did an correlation analysis between sleep quality and functioning, and the p-value was less than 0.05, and the rho value was 0.94, a negative, which showed that there is a strong negative correlation between sleep quality and functioning. So moving on to discussion, age was found to be statistically significant with functioning, and almost 60% of the participants was in their 20s. This study also found out that there's association between social support and functioning, and this is also consistent with some of few studies in the literature. And also, the support from family also drive meaningful engagement and also reduce patient relapse. So it's also observed that poor sleep quality was also associated with lower level of functioning. And this is also consistent with studies by Della et al. So the strength of our study is that we use standardized instruments. All the instruments we used were validated with good reliability, and they've been used in Nigeria by different studies. And the limitation is that it's an hospital-based study, so which means that patients with severe form of illness, where those that need treatment were actually the ones who saw. There might be people in the general population who have a mild form of this thing and will be excluded. There is also a cross-sectional study design, meaning that we can't infer causality. So in conclusion, sleep quality, social support are important factor when it comes to level of functioning in patients with bipolar disorder. And it's important that addressing any of these problems could considerably improve the functioning of patients with bipolar affective disorder. So these are my references. Thank you very much for listening.
Thank you very much. I want to remind participants that time management is also being scored. So please let's try and keep within the 7 minutes. Well done very, very much, sir, for that presentation. The next presenter is prevalence and correlates of aggression in acute care wards of a Nigerian psychiatric hospital. Please, can the presenter come forward? Thank you.
Thank you very much. Good morning, our distinguished guest speaker, professor, and our esteemed panelists. I'm Dr. Wigwe. I'm a senior registrar in this facility, and I'm representing the forensic research group. Okay, the title of our project is of aggression in acute care wards of a psychiatric hospital. Okay, to introduce, aggression is defined as the threatened or actual use of physical force or power against oneself or others, resulting in injury or death or harm, and it's often used interchangeably with the word violence. Studies have linked certain symptoms in individuals to aggression compared to the general public. Especially, aggression is of concern in psychiatric settings due to its negative effects on the safety and well-being of staff and patients, particularly the emotional well-being of staff. Next slide, please. Now, varying prevalences have found for aggression in inpatient settings, depending on different centers where they've been studied. For instance, we have 17% and 69% in Australia and India, respectively. Coming closer home, we have as low as 3.6% and as high as 19.5% in northern Nigeria. Common to all these studies are the identification of patient factors such as a history of aggression and a forensic history. Ward factors such as the lack of privacy and staff factors such as burnout and inadequate numbers have been identified. Now, few studies have studied aggression in psychiatric care settings, but very few have looked at aggression in acute inpatient settings. The aim of our study was to determine the prevalence and correlates of aggression among the acute care patients, inpatients of the Federal Neuropsychiatric Hospital, Yaba, Lagos, with the objectives of determining the prevalence of aggression in these patients and the socio-demographic and clinical correlates of aggression in these patients. Next slide, please. The study was carried out in the acute wards of this hospital, including 2 male and 1 female ward. It was a cross-sectional study, employed consecutive sampling, where patients were recruited as they were being admitted into the acute psychiatry wards between August 11th and October 8th. Patients aged 18 to 20 years, patients admitted into the acute psychiatric ward during this period, and those who gave informed consent or from whom informed consent was obtained from their relatives and carers were eligible for this study, and ethical approval was obtained from the Health Research Ethics Committee of this facility. The instruments used include the Mini International Neuropsychiatric Interview version 7.0 to ascertain the clinical diagnosis of the patient. The socio-demographic questionnaire was used to obtain the participant information their biodata. The modified overt aggression scale was used to assess the type and severity of aggression displayed. And finally, the brief psychiatric rating scale was used to determine the rate and severity of aggression in these patients. Next slide, please. Next slide, please. Now, so the participants who were eligible were recruited to the study after having obtained informed consent. Thereafter, the socio-demographic questionnaire, the mini international neuropsychiatric interview, and the brief psychiatric rating scale were administered. Then they were observed for the duration of their stay, their 2-week duration of stay, for any form of aggressive behavior. All forms of aggression were documented in the MOAS weekly. And at the end of 2 weeks, the highest score on that instrument was determined to be the severity of aggression for each patient. Data was collected using a proforma that was developed based on the reviewed literature, as well as the aims and studies and objectives of this study. It was analyzed using the statistical package for social sciences version 27. Continuous variables were summarized using mean plus or minus standard deviation or median. And the association between categorical variables was assessed using the chi-square test, while logistic regression was used to determine the independent predictors. Level of significance was set at 0.05. Now, for the results, 86 participants completed the study over the period with the median age of 34 plus or minus 18 years. There's a clear majority of employed patients among the participants, with skilled employment being most represented. Single males of Yoruba descent were also the most represented in this study. And our study found out a prevalence of about 38% among the participants, as shown in these figures, in the table and in the pie chart. Next slide, please. Now, the analysis was done using chi-square test and Man-Whitty-U test, as mentioned earlier. It revealed there was no statistically significant association between aggression in these patients and all the socio-demographic variables that were considered. Chi-square test also revealed 14 clinical variables were statistically significantly associated with aggression. And however, binary logistic regression revealed that only anxiety and excitement were the clinical predictors that were independently associated with the likelihood of aggression. Next slide, please. So those that information is displayed in this table. Next slide, please. Now, the prevalence of aggression among the patients in our study of approximately 38% is found to be way higher, almost double that found in other studies in Nigeria as well as in other countries. Our study found that socio-demographic variables were not significantly associated with aggression. This is not consistent with previous studies that were considered. However, clinical correlates such as having a diagnosis of bipolar disorder and some psychopathologies were also shown to be significantly associated with aggression in our study, which is similar to what was obtained from previous studies. And also, our study revealed that anxiety and excitement were the only independent predictors of aggression, which is consistent with some previous studies. Our study had some limitations. First of all, being a cross-sectional study, it wasn't possible to infer causation. In addition, as was done in our center, which is one center, therefore the results could not really be generalized to other settings. In conclusion, our study found a higher prevalence of aggression among the participants, and this means that a thorough clinical assessment and prompt management of psychopathology are key in order to minimize and mitigate the incidence of aggression. These are our references. Thank you so much for listening. Thank you for the opportunity to present our findings.
Thank you very much. Thank you very much. That was done to time. For Yaba residents, we've been told that if you see your residents are very happy, be on guard. Number 5, cognitive insights and its role as predictors of relapse among persons with diagnosed mental and behavioral disorders at Federal Neuropsychiatry Hospital, Yaba, Lagos.
Good morning, my consultants and everyone present here. Today we are talking about cognitive insights. Every one of us understand the importance of insights when it comes to management of psychiatric patients or patients with psychiatric illness. We understand that insight is a recurrent issue, and when patients lack insight, there's usually a major problem which we have to be a issue. So we are talking about Beyond the traditional insights, we're talking about relapse persons with diagnosed mental and behavioral disease. And I will be presenting on behalf of psychiatric departments. That's the research group C. These are, next slide. When it comes to mental illness, relapse is, in any diagnosis presents with more negative outcomes. You understand the issue of relapse has to do with non-compliance, low quality of life, and a lot of other issues. And this is as stated by the different authors. And from one place to the other, different areas, you find out that the prevalence is very high. And whether we like it or not, it's a recurrent issue which we need to deal with amongst clinicians. This clinicians not only focus on symptoms relief, because yes, we are trying to focus on symptoms relief, but these are issues that will not allow the patient to actually have a resolution of symptoms. And because of that, we need to deal with it. Next slide. While a lot of study focus on the contribution of insight, that's from the clinical insight perspective, that's the School of CBT actually looks at the cognitive insight. And what is cognitive insight? The capacity to use your thinking and belief to actually understand how to distance oneself from erroneous beliefs. If people cannot, some patients cannot look at things from a different perspective. And that's why cognitive insight consists of self-reflectiveness and self-certainty. Self-reflectiveness is about the capacity to look at things from a different perspective. Okay, yes, can we think outside the box? A lot of our patients cannot think outside the box. And self-certainty, when they have a high level of self-certainty, you find out that there's a problem because they are so convinced about their beliefs, regardless of external realities. So when they are high on self-certainty, there's usually a problem. You find out that they have a lot of delusions and a lot of things that they are dealing with. And all these things are issues that we need to deal with. However, there has been less focus on these areas among scholars. Yes, a lot of people have been looking at traditional insight. How does it impinge on a patient? How does it impinge on their performance? It is very important. This is really concern amongst Nigerian authors, and we need to focus on it in Yaba. So our aim, next slide. Next slide. Yes, the aim is to actually determine the role of cognitive insight, relapse amongst patients and diagnosed with mental and behavioral disorder. So the first objective is to determine the prevalence of relapse amongst persons with diagnosed mental and behavioral disorder. Then to determine the role of self-certainty on relapse. How does self-certainty affect relapse amongst people with this disorder? Then to determine the role of self-reflectiveness on relapse. Then to determine the joint predictive of self-reflectiveness and self-certainty on relapse amongst our patients. Next slide. So the design is cross-sectional, and the setting is the hospital. So the timeline was between September, October, and duration for this is a self-report. And then the second one, the part is actually interviewer rated. And within 25 minutes, this should be concluded. This was concluded. Then patients are patients of the hospital. Inclusion criteria are all patients once they give their consent. So if there's no consent, or if the patient is not stable, then every patient that has a PANS score that is lesser than the cutoff, we actually excluded. So these are sampling size. The sampling technique is actually purposive because of the time frame of our research. Then sampling procedure, we approach the officers in clinic. Then we meet with the patient. We recruit patient that meets the inclusion criteria. Yes, we use the following instrument: Beck's cognitive insight, which have those variables. Then the positive and negative syndrome scale, which has been used in this part of the world. Yes, ethical approval was given by the hospital board. Then data analysis was done with regression analysis and correlation. So first objective, you find out that the prevalence is actually outstanding. About 88.9 of our patients, that about 351 patients were 88.9 of them had is a repeated. That's a prevalence rate of about 8.9. So next slide. And one of the things that is also very important is the fact that on the scale for self-reflectiveness, we had a negative correlation of 0.70. That means as this self-reflectiveness increases, the rate of relapse actually reduces. As once you have a notch, a 0.7 increase in the self-reflectiveness, rate of relapse reduces. But self-certainty, as self-certainty increases, the rate of relapse also increases. So it's in the same dimension. So, and you find, please go back. You find out that the overall contribution of self-reflectiveness and self-certainty is about 0.77. That's 77%. That means these are actually major contributors to relapse rates. Next slide. So, a discussion. Relapse is very common among our patients, just like we have said before. Self-reflectiveness of our patients significantly reduce their tendencies for relapse. Then, self-certainty significantly increases the tendencies for relapse. Thank you very much.
A round of applause, please. That was also to time. Okay. We've had very, very, very interesting presentations. But for the brevity of time, it will have been an opportunity to explore them. But just getting feedbacks from our cohort breakout sessions, we probably have about 15 minutes to explore questions and observations from the judges. So I believe our pretty wonderful audience have listened to several of the research teams come up with their topics and their abstracts. At this point, we want to entertain questions. We would give a minute for all who want to ask questions to please raise up their hands. And if you don't want to ask publicly, you want to write it as a note. So we'll give a minute for all those who want to ask questions, after which we would give numbers and we can ask. So we have that time. So if you have a question, I'm thinking people in Team C will attack Team A so that we'll try to weaken the strength of their research, so that we can help. So you can nominate people from your team to hack other opposing teams. Let's find holes in the research. Let's critique adequately. Questions? I see an hand up already. I just want to give time for every other person who wants to ask questions. Questions? Any other hands? Okay, seems was well understood by everyone. Okay. Quickly, a question.
Standing on the existing protocol. Good morning, my teachers and my colleagues. From the presenter from the psychology, you made a very big blunder. Yeah, that's it. He said managing psychiatric patients. That is labeling. It's not accepted. Listen. Now, let me just, if you do that in an international conference, all the examiners will switch off. It's meant to be patients suffering from mental challenge. Thank you very much.
Thank you very much for noting that. Thank you. So we're entertaining only questions. Questions for. Thank you very much. Any questions? Okay, do you have a note? If you don't want to ask, you want to just write it down. Thank you. Oh, some people are online. I just heard a voice. So my hands are up. Our online team. Hands are up. Our online team. Hands are up. Our online. Our online. Kindly signify in the virtual room if you have a question. Also, you could drop it in the chat box so that we could read it out and give the respective presenters the opportunity to answer, provide answers to the question. Do you have any questions in the chat box, or do you have any hand raised? No, I must personally commend the medical student from OU for that very, very bold and brave presentation. At least I'm an MC. I'm not a judge, so my comments don't count. But that was very, very wonderful, and I believe it fulfills one of the ideologies and ideas of a research fair like this, to get younger people more interested in research, because that's how we pioneer the frontiers of knowledge. So to her and the entire team, the research fair from Yaba, which is them high regards for coming up with that. Do we have any questions on the chat box? Okay, so we have questions. Please, it will be good if we direct the questions to the particular group or the particular topic. Okay, this is for the first presenter. The first presenter is the first presenter on site? Okay, for the medical students. Beautiful, that's good. So number one, it said, how did you arrive at the sample size? And number two, was there any method used to determine how many students to choose from each school? Okay, ma'am, you want to come and answer those questions? The one question is, how do you arrive at the sample size? And if there were methods used to determine how many students you have to choose from each school. If you need your slides to answer some of the questions too, we could help with that too. You could help with our slides too, please.
Thank you very much for the question. I actually anticipated the question. So it was actually a consecutive method I used for the sampling method. It is not really like a convenient sampling, so to say, because we had some inclusion and exclusion criteria to it. It wasn't as if we just took anybody that was just interested. So we involved only clinical students from 400 level to 600 level. So it was not really like per se say convenient sampling, but consecutive sampling method. Thank you very much. I hope that answers the question. I think there's a second one.
There is also one more question. It was, how do you determine the lack? Sorry, let me just yeah. Okay, the sample size from each school. The sample size from each school.
Yes, the sample size from each schools too actually was, as we can see, it was not the same from the charts. There was discrepancies and all of that, but then, as I said earlier on, that was also what we used, and it was major. Let me say that one was actually a convenience because it was an online survey, web-based questionnaire. So,
then also another question: how did you determine the lack of understanding of postgraduate education?
Okay, based on that, we actually, there is a section of the research of the questionnaire majorly, so that says perceived gaps. Okay, yes, we provided some questions in the questionnaire that involved we provided some things in the questionnaire. I'm trying to locate the questionnaire actually.
Okay, so we can give you more time, but before you leave, I have a very good news for you, and this is coming from Dr. Wakwe, one of our teachers and examiners. It says, please, so we already have a winner here in spite of the results. Said, I have a prize for the final year medical students who presented on postgraduate medical education. Dr. Bilo Mojid, please give her my contact. Just for coming alone, you're already a winner. Please, a round of applause for her once again. So we have one more question. Okay. We have a question for forensic too.
Okay, thank you very much, the presenter, and then for the courage that you have. Okay, so we are told I have 2 minutes just to encourage you. When the question was asked, the method you used in taking your sample, if you are talking about sampling technique, it's either random sampling technique or non-random sampling technique. So since you didn't have your sampling frame, so it's so obvious because you said that it has to be non-random sampling technique. So I want to really appreciate you and the courage that you have. And then of course, you can also see me after this program.
Thank you very much.
Thank you very much, sir. And I really appreciate the corrections, and I will look into it and correct it as well. Thank you very much, everybody. I know it's not too much, and I know it has shortcomings, but then I will also try and be better in research and go further in it. Thank you very much, everybody.
Thank you. No, for those of us who are on social media, this might not, and who go for special stand-up comedy shows. The way things are going, she might just be the biggest winner at the end of today. Okay, so we are rounding off now, but a quick question for the aggression units, forensic unit. Sorry, I said aggression. my apologies, please. Since the aggression was documented only weekly, was there any way to determine if patients were aggressive at any point before the time scheduled for recording aggression at the end of each week? And then just briefly, someone give a comment that, just in an opinion, Dr. Timothy Adebowale, that the study on aggression is more of a cohort study than a cross-sectional study, basing it on the fact that it had a period of before the outcome came. He wanted to know whether there were any other way to determine whether the patients were aggressive at any point since the recording was done weekly. Should I read exactly as it was done to you? So, since the aggression was documented only weekly, was there any other way to determine if the patients were aggressive at any point before the time scheduled for recording aggression at the end of the week, each week?
Okay, thank you very much for the question. So what was done was that the patients were observed, and every single episode of display of aggression was actually noted and documented. It's not like only at the end of a week, that's when the aggression was documented. It was all the episodes of aggression, like I said earlier, were actually documented. And then at the end of the 2 weeks, the highest individual MOA score was taken as that individual's severity of aggression. I hope that's clear.
I believe that question has been well clarified. Thank you very much. So at this point, any comment from, we are rounding up this first session. Stay tuned for the second session. For me, I think this is one of the the striking parts of. I just in a few minutes I've picked a lot, and that's the beauty of research conferences like this. So we still have a second breakout session. Stay tuned and don't worry. I'm sure provisions are made to ensure we are catered for. You get so please, we still have to come. The guest presentation from our speaker all the way from United Kingdom, and also another breakout session of presentation of abstracts. But now we take an interlude. Do you want to have any comments for now? So next few minutes, you just want to network. You want to meet someone. We have very awesome people in the building. You get. Let's not just assume we know ourselves or we see ourselves every day. So pending when we receive people from the other session. So let's get out of our seats, connect with someone, discuss research ideas, get numbers. You get. Thank you very much. We have 5 minutes to do that, please. 5 minutes. Just while waiting for the others to come in. Take selfies that you share as hashtags. Research fear Yaba.
Hello. Hello.
So what do you suggest?
Here, please. In fact, I would have loved to put Professor Wakwe on a speaker. And it's been a wonderful session. And our teachers online, our trainers, and our senior colleagues, they've been making fantastic comments. And there's a particular presentation here that was done by a medical student. And we could see the relevance of that presentation. It's so wonderful that Professor Uwakwe, see if I can put it on. Hello, Prof. Can you speak? Let's see, maybe we can hear you, sir. Hello, sir. Okay, let me my teacher's mouth. So, Professor Uwakwe has given me the go ahead to announce that he has a special prize for that medical student that made that presentation. It's a wow. A round of applause. Let's appreciate our teacher, Professor Uwakwe. And it's because of the network issue that we are having. You will have loved to say a few things on that. Maybe towards the end of the conference, you may still have an opportunity to say a few things on that. So we really want to commend the effort of every one of us. It's been wonderful, stimulating, interesting, and really helping us to think outside the box. Thank you, everyone, and well done. MC, well, gradually we've moved to the guest speakers point now. There are a lot of people online from the UK, from other parts of the West, from Nigeria that have been waiting since 7 a.m. And they've been longing to listen to this guest speaker's presentation. From different organizations, they've been sending us messages. They just could not afford to miss it. They've been online for so long. We have different organizations. We have those from the NHS, of the all these names, something Cumbria. And we also have quite a number of people that have worked with our guest speaker. They've been here for so long. Dr. Raphael Ogbolu, who is also the CEO of Sopin Nigeria. We have Dr. Adepoju. We have Dr. Odebi, Dr. Mustafa, Dr. Regunam. We have quite a number of people that have actually benefited from the wealth of knowledge of Professor Adelekun. Just like when we mentioned at the beginning that we also have a colleague of our guest speaker, Barrister Sir. Thank you very much, from the UK. Forgive me, I'm trying to remember the name. Olaofe. Yes, thank you very much, sir. And while we are waiting for the citation of the guest lecturer, we also have quite a number of our senior colleagues that kept on joining us. Dr. Akinomi, Dr. Ogunlesi, Professor Odofia. We've mentioned quite a number. And we appreciate everyone online. Professor Badru, who has been with us for several years for the research activities of the hospital, and many other people as we move on. We also welcome Professor Atilola, who has been with us when we started the session. Thank you very much. We appreciate you. Okay, so I also see one of my teachers, Dr. Grace Ijarogwe. You are welcome, ma. A child psychiatrist by excellence. So we'll move to the citation of the guest speaker. Are you ready? Dr. Ajayi, are you ready?
Okay, so okay, we want to welcome everyone back from the second breakout, the TDC breakout session. I believe it was as exciting as it was here. Dr. Ogba, what do you want to tell us about the session at TDC? How was it?
Oh, it was very exciting. We had wonderful presentations, and I believe this conference will do something beautiful.
Yes, and that's importance of a conference like this. Not just fanning into embers the flame of research, but also increasing our understanding. You get in our clinical practice. It was really, really interesting here also. Talked around topics ranging from surviving as a researcher in Nigeria to how prepared medical students are for postgraduate studies. I know the studies showed that surgery was topmost. But who should tell them that maybe like half of those people in surgery will eventually switch over to something else along the way? Probably psychiatry. We also looked at sleep disturbance and social support. We looked at aggression in acute care wards. And we also found out that once your patients are very excited in the acute care ward, you should be very alert because it's a high tendency for aggression. And we also look at cognitive insights and its role as a predictor of relapse among patients with mental and behavioral disorders. So how was it dealing with the network glitches on your hand?
Well, we encountered some challenges, especially with connecting with our presenter from Calabar, but overall, it was sorted out in due time, which shows to highlight the efforts the members of the research committee have put in place to ensure that we have a hitch-free program. So we want to thank every member of the research committee, those that have been working tirelessly behind the scenes to make sure that this program is being aired wide and far. And we have received assurances that for the afternoon sessions, all pending issues will be sorted out.
Please, can you just, if your hands are not busy, put a round of applause for the organizing committee for this conference. It takes a village to make this work, and they've run really, really well. A round of applause once again for the organizing committee. So we'll be going into the citation of, we need the quorum house. We're continuing. We are being strained for time, and we want to finish in good time today. Some of us have a flight to catch to Canada. Hello? Some of us have a flight to catch to Canada by the end of today. So we need to finish on time.
Some of us are escorting those that are having a flight to Canada.
Oh, okay. When is your flight leaving?
By 2 p.m.
2 p.m. Okay, so we need to be done before 2 p.m. so that my co-host can leave on time. Okay, so I want everyone to be seated, please. To be seated, because we're about to go to a very, very important part of this program. We'll be reading the citation of our guest speaker. We are so grateful that he was gracious enough to oblige us to be guest speaker at this event. And I will crave his indulgence. Okay, I've seen it. Download it. So I should tell him to send it to my open my mail. So look at 20. Okay. Sir, once again, thank you for obliging us, and thank you for your patience. We do not take it for granted. Okay. I'll crave the indulgence of Professor Moruf Lariwaju Adelekon to stand even as we read his citation. Thank you, sir. Thank you, sir. Professor Moruf Adelekon is a well-accomplished. My apologies once again. Professor Moruf Adelekon is a well-accomplished consultant psychiatrist with extensive experience in clinical, academic, and research settings. Prof. Moruf Adelekon was born in Lagos Island to the family of late Pa Jimoh and late Alaja Morinat Adelekon on 22nd August 1954. He has a rich educational background and several professional qualifications from renowned institutions in Nigeria and the UK. He attended Massey Square Primary School, Aruloya, Lagos. Aruloya. Please, nobody should tell my father. I'm sorry about this. 1960 to 1967. Ibadan Boys High School, Ibadan, 1968 to 1972. He was senior prefect in a final year. Senior prefect in his final year. He also attended Comprehensive High School, Ayetoro, for high school certificates between 1973 and 1974. He then proceeded to the great Obafemi Awolowo University between 1974 and 1981, where he obtained his bachelor's degree in health sciences and also his MBCHB. Professor Adelekon obtained 3 other degrees in the UK, a diploma in psychiatry in Manchester in 1990, an MSc in psychiatry in Manchester also in 1990, an MRC Psych from United Kingdom in 2003, and FRC Psych, Fellow Royal College of Psychiatrists from United Kingdom in 2010. Please, a round of applause for that. His career spans several landmark roles. He had his residency training at a sister institution, the Neuropsychiatry Hospital Arrow, and obtained 2 fellowships from the Fellowship of Medical College of Psychiatry and the Fellowship of the West African College of Psychiatrists in 1987. He lectured at the University of Ilorin between 1987 and 2001 and was promoted to a professor in 1995. A round of applause for that, please. He's an astute researcher. Most of his research is centered on epidemiology and clinical aspects of substance abuse. He was, amongst many portfolios, a technical advisor on drugs and HIV, United Nations Office on Drugs and Crime, UNODC, in Vienna, Austria, between 2001 and 2003. Was consultant psychiatrist from November 2003 to August 2023 at Lancashire and South Cumbria National Health Service Foundation Trust, and local consultant psychiatrist at Greater Manchester Mental Health Trust from 11th December 2023 to 31st August 2024. Prof. Adelekon's professional journey in the UK includes a substantial period at Lancashire and South Cumbria NHS Foundation Trust, where he worked across various teams such as crisis resolution and home treatment, assertive approach, and inpatient assessment wards. He received numerous awards for clinical excellence and audits, highlighting his commitment and contribution to the field of psychiatry. He further contributed to the psychiatric care through roles as a clinical supervisor, educational supervisor, site tutor, and active involvement in committees and managerial positions at the NH Trust. His experience encompasses comprehensive clinical responsibilities, including patient assessments, Mental Health Act-related duties, tribunal and managerial hearing reports, and a strong focus on multidisciplinary team approach. He was a former chairman at the NASFAT Council of Elders for UK and Ireland. He's currently the chairman, NASFAT Agency for Zakat and Sadakat, Nazas. He's an Owu chief, Oganla of Araromi Owu, Agowu Abeokuta. Please, a round of applause for that. He's fully, now this is the most interesting part. He's fully jackpada after 40 years experience in the UK and is happy to be back home to serve. And with much pleasure, we are going to greet and welcome him to the podium to share from that wealth of 40 years of experience, even as he talks on research, clinical practice, training, staying afloat amidst dwindling resources, and quality and quantity, comparing psychiatric clinical practice, training, and research in Nigeria and United Kingdom. Please, with a standing ovation, a round of applause for our guest speaker today, Professor Adelekun. Thank you very much. I will invite you to the podium, sir, to wow us for the next few minutes. To be there.
Good morning, everybody. I want to start this presentation by saying, please allow me, those who are not Muslims, I just want to say Bismillah ar-Rahman ar-Rahim, in the name of Allah, the beneficent and the merciful. Without his permission, I wouldn't be here, and I wouldn't be able to say anything. So all glory to God. That's number one. Number two is to say a big thank you for Yaba Psychiatric Hospital for dragging me out of my little corner in Abeokuta to come and do this presentation. I am really happy to be here. Those who know me, they would say that Yaba is my second home. When I was doing research, I was always in Yaba. And I was well accommodated. So let me thank people who know me who are here. The Chief Bashegun, Bashorun Bashegun of Ibadan land. Dr. Ari Oladapo, he was my great friend. I was always in his house. I know the children then. They are all doctors now. And Yaba is second home. His second home. And I want to recognize also Dr. Ogun, who I know very well. I'll come to, but really from around 1983, 84, I started collaborating with Yaba. Even though I was in Ilorin, I was able to supervise a few projects in Yaba, you know, and I'm still good friends with those dissertations who are the dissertations I supervised, because one of them was so grateful that she presented me with something big. You know, I wouldn't say not money, it was something that I'll remember forever. So that's how close I am to Yaba. But before I go to other places, I want to recognize all my friends and colleagues who are here. Professor, the Lagosian Professor Yewande Oshodi. I won't show the lonely Ekwetedo. I hope half of the buildings have not gone 3-story like my own area in Aroloya. I can't recognize my house again there. I want to also specially acknowledge my friend, lawyer Yemi Laofe, who were classmates at Compro Ayetoro. So when I told him 2 days ago that I will be doing this talk, he said he will be here. And he was here before 9 o'clock. Thank you so much. Online, I have my teachers and friends who are there. I have my colleagues who we finished from IFE together, Dr. Franklin Adeyemi, who is ENT surgeon. He's been waiting since 9 o'clock. I have my other colleagues, Odutolu and others on the IFE 81 platform. They've been waiting all day. And we also have friends here from other institutions. I just want to say a big thank you to everybody. I want to, in a very humble way, say, I have no power, I have no knowledge, except that which Allah has given me. So if I say anything that is right, it's because Allah has made it possible. I'm not anyway special at all. I mean, I started from our lawyer. Those who know Lagos Island, that is Isaleko, our lawyer side. We are still very proud of our origin, but it was a very difficult environment. Remember the Onola football field. That's where Indian hemp smokers, young people, they are there. And then we grew up from that and then became doctors, became professors, worked in the UN. We can only thank God. We can and see how to give it back, give something back to the society. And that's why after 21 years of working in the NHS, I decided to come back home. I've always loved to be back home. I've always loved to, I miss Nigeria. Now, don't get me wrong. There are good things. I'm sure some of you are already processing your passport for the airport. So I cannot stop you. But remember, just remember that it's not because Oyinbo people love you that they are giving you visa. No, 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 no. It's because they need you. They need you to do the work to look after their own people because they are accountable to their people, which is the opposite here. They feel accountable. If they have 5 consultants missing in an area, they will do everything to recruit from anywhere in the world. So call it poaching. They call it recruitment. And they can recruit from Nigeria, Bangladesh, India, South Africa, everywhere, because they love their people and they're accountable to their people. So let's get that right. So whether you are in the UK or you are in Nigeria, it doesn't really matter. They use your service. They don't want to know who you are. Once you tick all the boxes, they give you the job. But be careful of those nice letters. When they are recruiting you, see very nice letters. You know, you want to jump in the plane immediately. But when you get there, they won't even meet you at the airport anyway. So you will start seeing the reality that you are just here to do the donkey job. And God save you if you can manage your resources and do something with whatever you earn. Otherwise, nobody cares. You are just an immigrant, economic immigrant. You do your work, you get your pay. The only difference is you don't need to know the accountant. You don't need to know whether, I want to Los Abuja. When is the salary being paid? I would have paid accountant. They are monitoring the accountant's car. Have you seen him? Oh, I saw him taking a bottle of beer somewhere yesterday. That is trouble. That is trouble. So you don't need to worry. You don't need to worry about all this. Look at the system, the UK system. When they say you are going to retire, they will start working with you. The agency will start working with you about a year before your retirement. You fill in all the forms. You get clearance from your hospital. On the day that your retirement starts, your money is in your account. Don't sleep. I slept and I said, no, they must be joking. I've not been going to Abuja coming back. On that day, I checked my account. I was almost fainting. It was here. You don't need to know anybody. So that is the difference. So I greet all my seniors, my teachers, Dr. Ogunlesi and others, my friends from the UK, Dr. Ogbolu, Dr. Adepoju, Dr. Maruf, Mustafa, and others. They gave me a very good time. All those recruited from here who have been doing very well, I must say. They've passed all their MRC psych exams. They are all in postgraduates, and they are becoming real consultants, I mean UK consultants. So they've done extremely well. But I think we need to do something which we've not been doing before. There was a day we lost a professor, a psychiatrist, and I was looking into the platform, the APM platform, to see how sober people would be. Lo and behold, I didn't see that. People were exchanging the normal jokes, and so there was not even any sobriety. So I thought we are part of a family, a big family. We should remember our heroes, our ogas, those who used to say, Oga, Oga, Oga. Is it only because we needed them at that point? And when they are gone, they are gone. I don't think it's a good way to treat our elders. So I have a list here that I want us to quickly go through. I think this is so important to me for this conference, that we need that culture to remember our leaders, not only when they are here, when they have left here. So Dr. Betta Johnson, Dr. Orija, Dr. Idowu Malomo, Ms. Jinadu, Dr. Muhyiddin Bakari, Professor Fatoye, who was the chief examiner only 7 years ago, Professor Yusuf from Kaduna, Dr. Haruna, we were in the same research group for the injecting drug use, General Adelaja, who was the chairman of the postgraduate, the Faculty of Psychiatry, when I acted as a secretary in 1997. Professor Famui, Professor Dejide, who misuse, Professor Lantawura, who took all of us to the Manchester program. He would happily recommend you. He wouldn't stop at all. He would make sure you get there and that you are comfortable there. Professor Morakinyo, who dragged me into psychiatry. Oga, I was so close to him. He would come to Abeokuta. I was a youth corper then. He would stay in my house instead of staying in the hotel. We were very, very close. Professor Akindele, Professor Ayo Binite, Dr. Michael Ekpo, Dr. Julius Makonjo-Ola. He started the residency program at Arrow in 1982. And he made sure all the junior doctors he recruited were coming to Luth for all the neurosciences lectures. Professor Irimisi, all of them. And we all went and passed all our primaries. How can you forget such a person? So I think we should also remember our teachers who are still somewhere active, who have served but retired. Professor Ogunremi is in America. Dr. Boyega Ogunlesi is in Abeokuta. Professor Judo Eari is in Owerri. General Okulate is still very active, shuttling between UK and Lagos. And we have others like Professor Gureje, Professor Abiodun, Professor Adewuya, Professor Udofia, Professor Yinka Omigbodun, Professor Ayina, Professor Joe Oba Adeyemi, and have I mentioned Professor Koka Rotimi? I can't exhaust everybody, but please excuse me if I miss your name. I think we should appreciate these people. Professor Uwakwe, And all the people, I've been seeing new professors on the platform. I hope today and next month at Ilorin, I will get to know people better. Professor Atilola is here. Professor Shudi is here. You may say I've spent 10 minutes, but this is far more important to me. There is hardly anything I'm going to say you haven't heard before. But we need to appreciate each other more. Look, this is Dr. Ogun. She's back. She's happy to be back at the center. She started this annual research project 7 years ago. And it's still flourishing. When she was medical director, she started it. And in her lifetime, is blossoming. It's getting better. So, and here Dr. Ladapo is still the social elite, the social psychiatrist. He's proud to be a psychiatrist. We don't want to know the balance in his account, but he is definitely not doing badly. Oh, a night. Yeah, that's fantastic. So now let's go to, I have about 30 minutes more. Yeah, I can now relax. Please, let's have 1 minute silence to those of our guys who have passed on. 1 minute, please. Rest in perfect peace. Yes. After thanking the hospital for inviting me, I need to tell you the background. How did I get here? I arrived from the UK on the 13th of September. I promised myself I was coming to sleep for 6 months. Just sleep, wake up, take Ogi in the morning, Akara, and then go back. And I went to my small corner in Abeokuta where nobody will catch me or see me. And then a phone call a week after I arrived. It's somebody from UK. And she said, Dr. Bello Monjid would like to speak with you. I said, I know her, but I don't think I'm owing her any money. And the person said, oh, yeah, she wants you to do a guest talk. I said, you want to kill me? When you know that I'm coming back to Nigeria to rest, that I have not even removed the name tag from my suitcase. And he said, Dr. Majid will call you. I've given her your number. I said, Oton, that is the end of the case. When a woman talks to you, you are in trouble. And lo and behold, she called me. And she said, okay, you still remember me? I was your student at Ilorin. I said, yes. We have this thing at Yaba, and we wonder. To cut the long story short, I'm here now. So thank you, Dr. Monji, because I thought I wouldn't be able to make it at all. And since that time, she calls me every other day. How do we have committed people. If you lose somebody like Bello Monji to UK, she will just be another economic migrant. She will just go to her clinic and nobody will even appreciate. They don't want to know her qualities. And nobody is interested. So this is what we have in our country that we need to appreciate. Highly driven, look at medical students doing research. Not just research, standard research that can be presented anywhere in the world. So let us appreciate what we have. We know there is economic problem, but let me just release this quickly. There is economic problem, but there is also the issue of your integrity. Who are you as a person? What can you tolerate? Can you stand up to the Oimbo and say, please, can you leave my office? I'm busy. And they look at you and say, oh, this doesn't look like a real economic migrant. I say, I am busy. Can you come back? Once they know you are that firm, they will start respecting you. Because we are not talking about salary, we are talking about principles. But you can do that better here. What the Oyinbo will do then is to find a way of kicking you out. They'll start plotting against you behind your back. And by the time you know, you are getting into trouble. But this is our country. This is where you can go to the medical director and, bear out your mind. When I was doing my research, I could enter anybody's office. Minister, anybody. I'll book an appointment and they will grant it. So please, not everything about Japa is gold, oh. Not everything about Japa is gold. There is tough. I was so relieved the day I got to the airport. And I said, I'm going back home. Because this is where, look, since I came 4 or 5 weeks ago, look at the recognition. Who cares about you? You've come to make money. When I told my last manager I was going to Nigeria, they looked at me with pity. And I looked at myself with happiness. They said, you are going there? Are you sure? I said, yeah, really sure. So that is one message for today. But I want to talk about clinical services, training and research. You can't compare Nigeria with UK. Like I've said about the pension, Next slide, please. So I've done the number one. I've done the context of presentation. Let's go to next slide, please. I'll be spending just one minute, but the presentation will be available for anybody who wants to look at it in depth. Now, NHS runs the healthcare system in the UK. It was established in 1948 after the Second World War. Healthcare to all permanent residents of the UK is free. Can you imagine? You are admitted to the hospital for 2 months and you don't think about the bill. At the end, you just take your bag and leave the hospital. When you have had CT scans, MRI, all investigations, surgery, everything, where you'll be paying 100 million here, you just take your bag. They even get a support worker to take your bag down to the car park for you. That is it. There is also private care. Well, all you have to do is register with your GP and you have your NHS number. Next, please. Now, funding of the healthcare in the UK is done through commissioning groups. They call them CQC. They have the commissioning groups is different from CQC. The commissioning groups, they take the money from the government and they are empowered to fund hospitals. Now there is the CQC, the Care Quality Commission. It's an executive non-departmental body of the Department of Health, and they regulate and inspect services. There is also the Department of Health and Social Care that develops policies and guidelines. There is the National Institute of Health and Social Care Research, and then there is the National Institute of Health and Care Excellence. Can you imagine that for 2023-24, 160.4 billion, 85% of the total budget of UK is done to NHS. And NHS is funded from direct taxation and also what we call NI contributions. Next, please. What about mental health services in the UK? Again, this is provided mainly by NHS. And there you have CMHTs, that's community mental health, social care, residential care, crisis intervention, hospital treatment, talking therapies. According to the Royal College of Psychiatrists, there were 13,170 psychiatrists employed in the UK in 2020 by 2022. I tried to get the latest figure but couldn't find it. There is a psychiatrist per 12,567 people in England. Next, please. Now, mental health trusts were founded a few years ago, maybe 10, 15 years ago. No, I think more than that, because by the time I got to the UK in 2003, they were already functioning. There are 54 mental health trusts in England, and they run the psychiatric hospitals. So you have Lancashire and South Cumbria Mental Health Trust, Manchester Health Mental Health Trust, GMMH. You have them like that. They give them the money, the funding to run psychiatric hospitals. And you can access the services of your trust through your GP. Your GP can refer you, or you can go to the accident department of a general hospital and get admitted, because there are psychiatric teams assessing patients there. And from there, you can get admitted to the hospital. Mental health services in Nigeria. I look for equivalent funding figures. I couldn't find it. Maybe somebody can help me at it. Because I wanted to put it side by side with the UK one. I couldn't find it. But I know there is out of pocket funding. People pay out of their pocket, and that puts the family under so much stress. There is also the insurance. I don't know how much that's happening in our hospitals now. How many of our patients are on voluntary or compulsory insurance schemes? Of course, we shouldn't say the government is doing nothing. If not, who is paying for the hospital? Who is paying for the consultants and the doctors? Yeah, the nurses, the psychologists, the maintenance of this place. You know, so government is making input. But is it reaching the people who need it? I think that's what we have to look at. 300 psychiatrists serving a population of over 200 million. So at the moment, we have one psychiatrist per approximately 670,000 Nigerians, compared with one per 12,567 UK population. As at 12th of October, when I was asked to do this talk, 12,196 Nigerian trained doctors were on GMC registration. Other professionals are also in short supply, severe short supply. I was talking to somebody yesterday, and I said, oh, I should be expecting a lot of nurses at this presentation. She's a director, and she said, sorry, Prof, you may not see as many as you expect. I said, where are they? He said, where your doctors go. I thought Jackpot was only for doctors. So, but let us not be sentimental about it. When you don't have a comfortable source of income to make your life comfortable, not just your life, your children, your family, and you've been in the medical school all these days, you use what you have to get what you want. So people, it's understandable. I know of a medical school where all the students in that group from their clinical 1 year have been planning on how to do PLAB. So as they are passing their medical school exams, they are preparing for PLAB. And I asked one of them a few months ago, how many of you are in the UK now? They said their class set as a platform, WhatsApp platform, and about 50% of the class was already in the UK. And these are brilliant, when I say brilliant, brilliant young doctors that we are losing to the other countries. But that is the reality. Now that if you send only 1,000 pounds to Nigeria, how much is that now? 2.2 million. 2.2 million. If you have 1,000 pounds, just send it to me. I will turn it into something good for you within 5 minutes. What kind of economy is that? What kind of economy is that? How can anybody survive? And then we hear some people are donating 500 million for flood victims in a country where people cannot put food on the table. So don't let's get sentimental, emotional. People have to survive. That's the bottom line. That's the bottom line. Now, services remain concentrated in 10. Now, let me give you the picture of the UK. I worked in Blackburn. Blackburn is a small town of 250,000 people in northwest England. You know how many psychiatrists are in that Blackburn hospital? About 20 in just Blackburn. And when you leave Blackburn, you go to Bury, you find another equally large number of psychiatrists. You go to Bolton, you go to Oldham. That's only in the northwest. You go to Wythenshawe. There are 20, 25, 30, not just general adult psychiatrists, old age psychiatrists, child and adolescent psychiatrists, forensic psychiatrists, well funded. And if there is a vacancy of 2 or 3, you will see the country running around looking at how to recruit. When are we going to get there? Even if we cannot have these big centers, can we not make sure that in the primary healthcare system, services are available? Pa Yorinde did something like that in Abeokuta. Lambo did it in the 1954, 58, the Arrow Village system. And the Pa Yorinde, up till now in Ijebu, I don't know whether they are still running it from Ogun State. Patients could go from their home, receive their depot injection. They don't have to travel to Abeokuta. Are we going to be able to do that and help our people? Can you imagine traveling from Ijebu, go now to Abeokuta, and going back, apart from buying your medications, and then you pay for transport? You're looking at a lot of money that people cannot afford. Even the 70,000 minimum wage will finish if you do 2 of such trips. So I think this is where we are. Now, very little or no services at primary care level. I know Yaba has a community psychiatry section, but I will welcome comments on how we can improve that to even get better output. There is 90% treatment gap, as mentioned by Professor Taiwo Obindo in 2022. The good news is that we now have a Nigerian National Mental Health Act, which was signed into law on the 5th of January, 2023. What are we doing with it? Are we already using it? Are we respecting the rights? This already signed into law. Are we using it to bring patients to the hospital, involving full assessment with other professionals, respecting the rights of the patient, respecting the rights of families and carers? Are we doing that? How is this bill? I don't know whether I have to read it. I have to get a copy. How is it meant to help all the gaps we have in our mental health studies? Now let's move to the next. So this I will take only 30 seconds. You can't compare an elephant with an ant. UK, we've said, extensively diversified and specialized services available far more in the UK. Also, professionals are there at very high professional patient ratios. And the services encompass robust, wide-ranging physical and psychological and social care. Services are free, except for patients who opt for private care. Some people go for private care. Standards of service are regularly regulated and checked by Care Quality Commission. And when the CQC is visiting your hospital, everybody will be jittery because they are going to go into wards, they're going to talk to patients, they are going to talk to junior doctors, to consultants, and they will come out with results for the hospital, whether you are in the green zone, yellow zone, or red zone. And they have the power to strike out some services or even the whole hospital. Are we having anything similar to that in the country? And patients, family carers are encouraged to participate in care. Most of the psychiatrists in the UK are foreign trained. When you go to Lancashire Care now, Indians are majority. Guess who is next? In fact, the ward where I worked in Manchester, in North Manchester, you think you are in Oyinbo. The care, the support workers, when I enter the ward like this, and the nurses, the Oyinbo nurses will be wondering what are they saying. There is one who is an Alaja who dresses with hijab. As soon as I open the door, Salam alaikum, sir. I'm in trouble. So I was complimenting them. I was telling one of the senior managers, I said, many of my people are here. She told me, yeah, we know. We know, but their behavior sometimes, they will bring food and put their leg on the table. And I then reminded her, I said, but they are very, very hardworking. They get on with the patients. And you know Nigerian music is popular. Sometimes the patients will start playing all this popular Nigerian stuff. And our staff will start dancing with them. So that is, and Nigerians are providing good quality service. In fact, when you read, I went to do locum in Manchester, and a Nigerian was the consultant there before I got there. Anytime I read his records, I felt quite proud. Good quality stuff, you know. Next, please. So, yes, interesting place here. Clinical assessment management is largely the same. I'm not encouraging you to jackpot, but don't worry about your performance. If you have trained here for 2 years, when you land in Manchester today, the following week, it would appear as if you've been there for 2 years. Because what you do here is very intense. How many patients do you see at the accident and emergency here? 40, 50? Whereas there you see only 5 or 6 patients, all booked for you. But for those 6 patients, you are going to do a thorough job. All investigations, communication electronically, and then you have to write to the GP. And you are not going to carry it to the next day. So you end up with 6 patients staying in your office till 5 o'clock, 6 o'clock, every day. Next, please. Please go back, please. Now, I've talked about communication. In Nigeria, we use a lot of our initiatives. It's like you are playing football, and you can dribble from back to front. Nobody is putting you in straight jackets. Whereas most of people who are trained in the UK, they are like zombies sometimes. It's nice guideline. Even when things don't make sense, They are still talking about NICE guidelines. I said, look, can't you think? No, according to the NICE guideline. But remember, that is the only way to defend themselves. If anything were to go wrong, I use the NICE guideline, even when you have killed the patient. And then they will find a way, oh, you use the NICE guideline. Are we already using the NICE guideline in Nigeria? The good thing is abundant availability of investigations. You can do everything. You can just order it. CT scan is like routine. And you can order ECG. Nurses have been trained to do ECG. Doctors have taken up interest in ECG. So if you need ECG on your patient, and there are some medications you don't start without ECG. And they will do it within 10 minutes. Your junior doctor or a nurse on the ward will do it quickly and come up with a sheet for you. Just mention the medications. The paliperidone monthly, paliperidone 3 monthly, everything is available. And you don't need to worry for cost. For the expensive ones, all you need is approval of the pharmacist. Now, to leave this page, I have to warn us. In the UK, there is right of the patient, right of their family, right of their carers. If you mess up with any of these, they will complain. And they are very good at complaining. You wonder how they get the address of the complaining route. But they will complain quickly. And they will investigate. If you don't treat them nicely, fortunately, the GMC, the General Medical Council, has a lot of guidelines that you need to study to be able to survive in such an environment. Also, remember the powers of other professionals. In Nigeria, the consultant is the boss. Not so in the UK. You are the boss to the extent that you have to do your job. But you cannot do your job without the cooperation of other professionals. Remember, the nurse is the budget holder. The nurse is the budget holder. So the nurse can say whether or not they still need your post. She's still a nurse, but she's the one holding the budget. So she can say, I know in boss, they don't need to put knife on your neck to kill you. So I don't think we need that post again. We may have to do something about it without saying that you have done anything to her. And then the nurses will do their work, but you have to respect them. They will do their work thoroughly. The pharmacist is the boss. Do we have a pharmacist here? The pharmacist has been trained from the university to check everything the doctor does. So if you write risperidone and use another medication that has counter effects or dangerous effects, the pharmacist will point it out to you. It's not about whether you are a doctor or not. You have to discuss. If you are not comfortable with the pharmacist's advice, you can have a chat about it. Well, you cannot go ahead and just do anything. Sometimes they feel like a pain in your neck. Well, it's a very good neck, a very good pain if you want to survive in the system. So you go there, you have to be ready to collaborate with other professionals. Next, please. I'll be quick now. In 5-10 minutes, I should be training. I'll just say about the details. You can get a copy of the slide. But there are 2 steps to the training. There is the core training, where you get your MRC psych. You do your 3 years in different specialties. And then there is the higher training, where you go and work in your subspecialty of interest. I've listed them: child and adolescent, forensic, general adult, old age, psychotherapy, and learning disabilities. And you can do others sub-interests, sub-specialty interests, addictions, eating disorders, and so on. Go on. In Nigeria, we have 2 steps to training. There is a core training, 24 months, and then there is a senior training. Most people will pass their primaries even before joining the program. And then detailed curricula. If you look at the curricula of the National Postgraduate, it's so detailed. I was asking somebody yesterday, do you follow this detailed, curriculum? And she said yes. And this curriculum is highly respected in the UK, because when some of our colleagues wanted to get their fellowship in the UK, the Royal College of Psychiatrists asked for this curriculum. And once they saw the depth of it, they approved it. They started putting them on specialist register. So that's what I would say. Let's go to the next. Again, for a senior psychiatrist, a senior doctor in training, so much details about what you have to do to finally submit your dissertation, pass the exams, and become a consultant. Next, please. Yeah, go on, please. How do you compare the 2 training programs? Both have clear pathways. Indeed, the Nigerian program, by including the submission of a dissertation for Part 2, has the newly qualified fellow for multiple roles, including academia. From my 2 dissertations, I was able to publish 4 papers, straight even before starting my work as a lecturer 1. And so it was a very good step to becoming a senior lecturer. All I needed was to add another 3 or 4 publications then, and then I was able to submit within 2 years of starting my academic work to become a senior lecturer. So our dissertations, look at a medical student presenting. Can you imagine that medical student becoming a psychiatric trainee and then start publishing even from medical school? And you can move up and you can develop your self-confidence. Remember again, working in the UK is about providing services. It's not about you writing papers. Nobody cares. Now, UK program is well subscribed, but the Nigerian is depleted, is malnourished, it's quite shocking. And I understand to even get enough trainees to come for exams now. You're almost begging them. When I was the secretary of the Faculty of Psychiatry, we would have, for primaries, we have over 45, 50, and we will pass maybe half of them. But I understand that's not the situation now. Now, even the trainers are also going out of the country. What happens to the remaining trainers? They are fully stretched. They have to survive as individuals, as family members. They have to supervise trainees. They have to survive in their own life. And they have to do multiple and see many patients. 2 minutes. Okay. So let's go to the last bit. I have 2 minutes left. Research, quickly. Look at UK, well-structured research bodies in the UK. Next, please. Clear research goals. And there is partnership with all sorts of organizations. Clear research goals. 6.1% of the UK's health research budget is spent on mental health. 6.1. Now, just in 2021, there was a boost of £30 million for mental health research. As if that is not enough, in May 2023, there was additional 42.7 million pounds investment. They call it investment into mental health research. And the Royal College is still shouting, this is not enough. You need to give us more. Go on, please. I then went looking for the funding for the Nigerian mental health. The only funding I found was the one from Yaba Psychiatric Hospital. Let's give them a round of applause. Where they give young doctors and so on token amount. 7 years ago, Dr. Ogun, please stand up for recognition. Because what we do sometimes, we follow us. She was the medical director then. Please sit down. And she started this. Started with, however, see the impact. Annual events. ABA. They are also current prolific researchers. Next, please. So where do they get the money from? Only a few well-renowned researchers are getting international funding. And I understand it's like the camel passing through the needle's eye to get some of this funding. Institutions still give some little money, Senate research grants, Yaba research grant, and so on. To opportunity to even attend conferences. Where are you going to get the money from? Next. So we don't need to spend, I've compared both. Next, please. Recommendations. Integrate psychiatric services at primary care level. Include mental health patients under highly vulnerable group and heavily subsidize their payments. I don't know whether that's going on already. Better funding of services by government and private sector. Training of more professionals to fill the current shortages, not to provide them for UK, but at least you still need to train more. And then give more incentives for trainers and trainees in Nigeria to stem the brain drain tide. I don't think it's too much for the minister or the government to say, we have a special salary scale for health workers, doctors, pharmacists, and so on. Resuscitate the 1 year abroad exposure for senior trainees. Centralized and better funding for research. Encourage our diasporan doctors to collaborate with Nigerian institutions in service provision. Hospitals, you can invite them when you come on your holidays. We'll put you in a guest house for 2 weeks, all funds paid, and just come to the clinic, run our clinic with us. Or you can be doing online. Start some collaboration. It will be money well spent. So I'm appealing to the directors who are here to support such more. The same thing with pharmacists. The same thing with pharmacists. The government, the APN, and the colleges should give annual awards to individuals and institutions who have displayed excellence in service, training, and research. I got 6 excellence awards in the UK when I was still a substantive staff. And how do they give you this? They look at what you do, you complete a form where you show that you are doing more than your contracted work. For instance, if you form a patient family group, and you're educating them, and you are doing, this is outside the contract, and you are able to write a report on that, that can fetch you an excellence award. And what is the award? They give you a sum of money. It used to be pensionable, but it's no longer pensionable. Well, you get some little extra on your salary. If you have done 6 of that, You know how much that is on your salary. Encourage people, encourage excellence. Now, today, the medical students are awards. Let's do more of that and appreciate ourselves, appreciate our values, and encourage Nigeria to go to greater heights. Finally, I forgot to say thank you to Dr. Gbenga Oweye. He's doing fantastically well. We are very proud of him. Thank you, Yaba, for inviting me. Thank you.
Wow. Please, let's keep clapping for the guest speaker till he goes to his seat. So many reflections, so many talking points.
Yes.
Very insightful presentation.
I took note of very important points that he raised, and it's a moment for sober reflection.
Oh, some of the ones he took notes of, Dr. Oba.
Okay. You know, he mentioned that in Nigeria we had one psychiatrist covering 670,000 people in the population.
That's serious.
So
that's
the capacity of Lagos National Stadium is 55,000. So
that's bringing it in context.
12 stadiums, one psychiatrist.
One.
To cater for 12 stadiums.
That's so much. And I'm happy to see Professor Atidola here. I was at the NAT conference last month when he was even giving us updated figures on that, when he was talking about the capacity gap. I think we are approaching over 1 million, if I'm right. These are a cause for concern. For concern. We'll open the floor for questions and comments. We'll open the floor for questions and comments on this presentation. So we'll give room for people to raise hands and ask questions. If you have questions also on the Zoom platform, our audience was listening ardently on Zoom. I'm proud to announce that we hit over 200 attendees on the Zoom platform, as much as present on the physical platform. Please, a round of applause for the committee once again. So while the presentation was going on, the NM chairman for the Lagos chapter walked in.
BKS Said, you are welcome, sir. We also appreciate all our elders joining from time to time on the online platform. We have the alumni of Yaba Federal Neuropsychiatric Hospital too, online since morning. You're welcome, sir. It's really exciting to see my my powerful mentor who actually took me up when I was about to start psychiatry as a copper, when I was wandering in the wonderland. And he said, yes, we will groom you. And he did. And since then, he's been on my case that, yes, I must thrive in psychiatry. Professor Olurotimi Kokasa.
By raising your hands. Okay, I see one hand raised. Second hand. So the hand at the back won. The second hand. Please help us also look on the virtual room if you have questions. So there's a hand at the back. A hand at the back. We ask all the questions once, then we would the hand at the back. No, there's an name. Yes, thank you. Then we'll give our guest speaker the opportunity to answer them.
Good afternoon, our special guest speaker, Professor Adenekon. I used to know you too when I was still young in this hospital. Sir, with your comparison between psychiatric management or research over there at the UK and here in Nigeria, that's trying to give me, you mentioned something, some of this, that the treatment is free over there, is cost effective here. And we find that most of the time, we still find some of our patients come from abroad, from UK down to Nigeria for treatment. I don't know, I now, because I thought it's more expensive over there. That is why they come to Nigeria. Should we now say that the treatment here is better than there? For comparison there, the treatment there is here. Although we have, you know, the internet and the knowledge here too as well, that is comparable to that place in UK. Now, if we have people coming from UK, our people sending their patients down here for treatment in psychiatry. Likewise, I know that we have our affluent people, our guys there, our leaders going to abroad for treatment too. If it is free over there, and we have people moving here over there, and some people are coming over from there, what is your, is there any, and say concerning that is my question.
Thank you very much. Thank you very much, sir. Yes, we have a lady here. The lady you initially wanted to give the mic. No, come forward, Dr. Gwen.
Good afternoon, everyone. My name is Chika Okoromadu. I'm a storyteller and filmmaker, and I run a storytelling agency that helps to raise awareness on societal issues to key stakeholders. And our current focus now is on mental health, which is why I'm here, because, you know, when you're reporting such issues, it's good to get accurate information. So that was why the research was very attractive for me to be here. So my question is to Sir Adelekon, right? That's the pronunciation. It was very insightful. If you were to summarize the issues that the Nigerian mental health system is having in one statement, would you say it's a structural issue or a funding issue? And I know that you highlighted, you know, channeling these issues to the government and the public sector. Who will be the first? Like, I know that the government, you mentioned that the government is already doing what they can. Do you think that the public sector, you know, needs to get involved more? The reason I'm asking this question is because at the end of the day, even as a creative, I'm not a medical professional, but I think that there are ways that we can collaborate together to create awareness and channel this message to the right body so that action can start to happen. Thank you.
Thank you very much for that question.
Thank you so much, Prof. It's really an honor having you back in the house. My own question is similar to the first person. We have this group of, I work in child psychiatry, and I find that many of our patients that travel out of the country for better life, better treatment, better scope of, well, let's say advanced rehab for many of those children with neurodevelopmental disorders. They call back, looking for ways to come back into the country. Some of them have gotten jobs outside the country, but they will now look for auntie, uncles, whoever to take care of this child while they relocate the child back into the country. We don't have a lot of the sophisticated equipment for rehab and all of that, but what they tell us is that they are on the waiting list for 2 years for 19 months and those kind of things to see a specialist. And during this time, they will not have access to medication. They can't just go to chemist or anywhere to just go and buy drugs the way they follow themselves up and buy our medications if they don't come back to clinic. They have to wait, and the children will relapse and all of that. And some of the children actually get aggressive. That it's the system that has not created time to see some of these children. I had a child last year that had to be brought back into the country because she almost got the father into trouble. She told the father, she called immigration that the father is trying to rape her. She was being managed for bipolar affective disorder, and I think she became she actually accused everybody in class, all the boys in class, for looking at her one kind, trying to sexualize her and all of that. But the hospital still did not think it was an emergency for this child to be seen until it became such a crisis that the father had to package her back into the country. So I just want you to help comment on this. Thank you.
Okay, there is one, and yeah.
Thank you, Prof. I'm Dr. Amosu. I'm from Harrow. Prof is a rare kind of being. In my 24 years, now 25 in Harrow, Prof has always been coming. In the days of Dr. Ogunlesi, Dr. Akinyomi, Dr. Adeboale, one way or the other, Prof will come. He will give us lecture. He will go back. I think people should take a cue from that. You can't take that from Prof. If you want to know whether Prof is around, just ask Dr. Akinyomi. He will tell you. Or God will tell you, when we're around, you will know he's around. There is this trend that I want Prof to comment about. Our children are growing abroad, good. But how will they be like Prof, who comes home regularly? Aside from finance. Recently, I'm a pastor in Redeem. An elder fell at home. I was rushed to the hospital. So he survived it. He had borehole. And if you see the amount of blood that came out, one way or the other with physio, he recovered quickly. But do you know the problem? His first son is a doctor who has been in Canada for over 20 years, has not come home once. Once, he has not come home. I don't know where we got it wrong, that we have raised some of these children that it's as if they don't send us again. Where did we miss it as parents? Yet I know somebody who had been in UK for over 20 years, who will come at least twice a year. He will spend Christmas with grandma. Even when grandma was sick, he came. He will come, spend 1 week, and rush back. I think Prof should just help us. God must help us to get it right with these children. We know they want to travel. Some of us are not going anywhere, but they keep drumming it. And we see our king. Thank you very much.
Thank you very much. Any other questions, comments?
Thank you, Prof. I'm not a psychiatrist, but Prof taught me in medical school, University of Lorry. When I saw his name, I was I said, I'm 40, how many years ago? I will see Prof today. But it was my teacher in the University of Lorry, long time ago. Now, thank you very much. Even what the doctor has said, I'm very, very happy. Because I was asking some people few months ago that we are talking about JAPA. We are limiting JAPA, relating to what he said, we are limiting JAPA to government. And I realize that this JAPA beyond government. Some of us, most of us, we have our children in medical school now. Are we thinking by the time they finish, where will they be? At the end of the day, who would lose? The government and the parents. Sir, how can such thing be solved? Because a doctor has said, if you have children and they are out, you are on your own. In the next 10 years or 20 years, if you don't do anything, I will call different Dr. Osu, I'm sick, you come and treat me. You are going to that stage. Another thing is that this thing happened, I don't want to mention the College of Medicine. It happened last year, it happened this year again. Medical student committed suicide. These are part of the mental health. What can be done? Thank you, sir.
Thank you, everybody, for your questions. Time is fast spent, and I'm sure people are getting hungry. Why are people coming? That's the first question. Why are people coming from the UK for treatment when it's meant to be free over there? It is free, but it's not El Dorado. For your GP to even refer you for treatment, for specialist treatment, it may take months. I mean, I had some musculoskeletal problem about 2 years ago, and I was referred, and I thought, oh, I'll see physio within 2 weeks. I did not see anybody for 6 months. So I went private. It was when I was about to start my treatment in private that they say, oh, they then wrote me, they now have vacancy. I said, it's too late. I've already paid the private. So even though the treatment is free, NHS is oversubscribed, is overstretched. You'll be surprised to see your cardiologist. Maybe you will have died, you'll be in second heaven. By the time you, it is really difficult. I mean, I'm a consultant in a hospital. Why should it be difficult for me to see another consultant? You will wait for 6 months, 9 months. So that is the way because the queue is so long. The queue is so long. Chika Okoromadu, what problems is mental state and mental health facing in Nigeria? Chika, are you still here? Yeah, that's a very good question, but I don't think I'm in the best position to answer it. I have my colleagues here who are really current, who know what are the problems. So if you can give any of them, Professor Atilola, Professor Oshodi, any of them, Professor Kuka, just tell us what are the issues. Because I don't know the funding, whether the funding is diminishing, is increasing, whether government is thinking of community mental health, putting some big money down for it. What, I don't know. It will take me quite a few months or a couple of years to get back to getting to know some of these things. Waiting list for 2 years with patients, I've just mentioned that. But do we actually underestimate the importance of what we have in Nigeria? I know a family whose son has learning disability, a family in Lagos, and they got this specially trained woman who comes to the house to train this child with cognitive problem. Can you imagine within 1 year, that child is able to read 200 backwards and skipping, and he can actually read 135 odd numbers up to 300, and yet still learning disabled. We have people, we have resources locally. Nobody's going to give you all that time abroad. The physiotherapists, the psychologists, we do 30 minutes. It won't be 1 minute more than that. And if it is 5 o'clock to go home, he will not walk 1 minute outside the 5 o'clock. Unless you want to go private, where you pay for a number of hours, and they will treat you for those hours. So, Bowo Shemo. Doctors abroad who don't come home, I think it stems from how did we get abroad to start with? Did you go abroad with frustration? Did you go abroad because you don't have a job? Did you go abroad that is just by chance? I never wanted to jackpot. Those who know me in Yaba, I was busy. I was doing a WHO. Professor Koka is here. We were in the same research team. We were looking at injecting drug use all over Lagos, Oshodi, Ojuno, everywhere. And we were traveling abroad. We went to South Africa, went to Atlanta, everywhere. But by one reason or the other, I found myself in the UN, from the UN to the UK. Called that modified Japa. But now it's out of desperation. When people don't even see, I used to boast in the UK that my junior doctor, they are training, they have built their first house. Because the first thing they will do is to buy a plot of land. They won't tell Oga, but by the time they finish their training, Oga, Afesha draws Ilekon, you know, and then you go, want to quarry, it may not be painted, but it's house. They won't be tenants again. When you don't even have any choice, any chance of doing. Now, parents are already thinking, my daughter is a fourth-year medical student. How can I get more from my investment? I used to live in Ikorodu, and there was this man. He wasn't the most comfortable, but he invested money to get the daughter to come and spend 4 weeks with me in Blackburn to be able to get references in preparation for Jackpine. And the daughter is back now, flying high. She called me in August to greet me for my birthday, and she continued to thank me. I said, no, you have to thank your dad. He invested in you because he doesn't know how the Nigeria will turn. That was when the Naira was 250 Naira to a pound. Now it's 2,200. So I think we are in big problem, and we just pray there will be some reversal of some of this economic hardship. Thank you very much.
Thank you very much. So as a member of the emergency department, Yaba. Okay.
I want to comment and thank the participants. Well, I'm so happy and delighted about this program. Please let us clap for ourselves first. That's number one. Number two, let us clap and give a standing ovation for the guest speaker, please. Standing ovation. Please. Because he has done very well. Please sit down. Now, thirdly, I want to thank the management and the staff of Yaba Psychiatric Hospital, of which I'm just also part of them. Please thank Yaba for me, all of you. Say thank you, Yaba. We want to thank the founding fathers of this hospital, the founding fathers, starting from Professor Peter Johnson, Dr. Orija, late Dr. Malomo, and Lawal, and all of them, for the vision. Because you see, if you don't have a vision, you cannot establish a system as Yaba here. We used to be proud when we go to the presidency in those days as CMD or whatever, and that we are Yaba people. Most of the things they are discussing, we have done it already in Yaba. We've done it. And that is why it is very difficult for our nurses or doctors to go on strike because of money. We will have paid everything then. But because they have to join their union, and that is why, look at everybody well-dressed, well-composed, doing very great. No, this is the truth. Listen, gentlemen, if other institutions copy what they are doing in Yaba, with the research, as I mentioned, I think Nigeria will be a better place. Why I blame the government of Nigeria is that they don't use psychiatry or psychiatric practice in the annals of their programs and policy making. I remember in those days, the chairman of a Senate Committee on Health, he's a psychiatrist, Martin Cielo, was a psychiatrist. He followed us to pioneer him on Mental Health Act in 1990. Nothing came out of it. Even the Mental Health Act that has been just passed, I don't know, Professor Kwaka is telling me that it's been reviewed. I don't even know whether it is working or not. But we need visionary leaders in psychiatry. We need all of you here, many of you young people here, are going to assist us. We are getting out of the stage. We struggled in our own time too, but we survived. I promised myself and Dr. Malomon that I don't think we should go abroad. Things were difficult in those days too, but we promised we are not going abroad. We practice social marketing, social psychiatry, and that is what happened to us. But I will not tell my children not to go abroad when they were supposed to go. No! My daughter finished the West African National College at Lut. She was living in Agege estate there. She has to come to Lut. The other daughter finished in Nasucom. That's a student of Professor Coca. They are both in America. You understand my point? My son is a lawyer also. Went to UK with his wife, American doctor. No, dollars are not coming. No. That's not. I'm not happy about it. It is not good for me as an old man. It is not good for me. I want them to be established, and that is why we spend so much money to invest on them. I want to encourage you. I don't believe in people going abroad, but I believe that you can establish within the communities here. There are things you can do to assist and make sure that you live well within the environment here. We need to appeal to the government to change policies, to have visions on who is going to be in charge. It's not a matter of just putting me as CMD, and then I'm in charge of allocation, and I'm supervising infrastructures, and so on and so on. That's not the case as it may be. I remember, is it not Atiloda of UCH in those days, when you were in charge of NARD, isn't it, with Ilestami? Yes, I remember you. When I was in charge of conflict resolution by the presidency. Yes, look at you today. You are not Jackman, you are here. These are the... No. I don't think so. God will bless you. I want to thank you very much. Alhamdulillah. You are a member of the Lions Club in those days, isn't it? But you are now in NASFAT or whatever. I'm now your Baba Ajotu myself. God is great. We are going to go on tea break. And when we go on tea break, we shall talk more. There must be social interaction. There must be networking. I'm networking with Gis. This my friend here. I'm networking with them on issues about what we can do in the diaspora. You know? And that I think that your life has just started and shall never be the same again.
Thanks to our Baba Ajoba Ashegun worldwide. That was wonderful. Good afternoon, everybody. It's time to have our tea break. I want to beckon on our dignitaries. Those of us on the high table, kindly take a step to the back to have your choice of tea. After, if you are with me tickets, you will join them one after the other. For those of us that are not with me tickets, just relax. Calm down. Yes, thank you.
I
Auntie, calm down. Thank you very much, my welfare chairman. So, as we are taking the tea break, for those that are interested in going to the poster session, we will do that as the TDC. And within 5 to 10 minutes, or maximum 15 minutes, we will have the next session, the next breakout session. Thank you, everyone, for your attendance, for patience and everything. We appreciate you and we value your time. Thank you.
Okay. Distinguished ladies and gentlemen, we are about beginning the afternoon session. So while we round up our tea break, studies have shown that after the introduction of tea break, attention and concentration is increased by 92.419%.
What's the confidence interval?
It's evidence based. 95%. So we believe that our attention and concentration has been significantly increased.
Hope there was no conflict of interest.
No conflict of interest. So we'll be going on to the second sessions of presentations. The following presentations will be done at the TDC building: hematological and biochemical profile of children with cerebral palsy in a neurodevelopmental clinic in Lagos, Nigeria. Psychosocial factors predicting treatment adherence among patients with schizophrenia attending Federal Neuropsychiatric Hospital, Yaba. Personality traits and self-esteem as predictors of psychoactive substance use among commercial bus drivers in Lagos metropolis. The role of medical laboratory services in mental health practice, a scoping review of evidence. And then finally at the TDC building, we'll be having mathematical model of the role of family support system in substance use treatment.
For the presentations here at the conference hall, we have prevalence and correlates of domestic violence among patients with severe mental illness in the hospital setting in Lagos, Nigeria. We also have adverse childhood experiences, negative social comparison, and body image dissatisfaction as predictors of early onset of depression among young adults. We also have barriers to mental health services, utilization in Sokoto State, Nigeria. We also have psychosocial correlates of depression and suicidality among people living with spinal cord injury in a tertiary hospital in Lagos. We also have the pattern of clinical presentation and determinants of clinical response in patients presenting with first episode psychosis. So
okay.
Presenters and the judges alike in TDC. Can you just reel out the judges in TDC?
Okay, for the judges in TDC, we have Dr. Stephen Oluwani, Professor Yewande Oshodi, Dr. Yeshiru Karim, and Dr. Sunday Amosu. And so for our presenters who are presenting online at the TDC, please you join the TDC link at the Zoom platform. The breakout session, you join the breakout link on the Zoom platform, which will take you to the online presentation platform for those presenting at the TDC. That is where you'll be presenting, while the rest of us can join here. So presenters should please go to the TDC building where the presentation will start in earnest.
Our panel of judges here at the conference all include Dr. Oluwayemi Ogun, Dr. Olufunmilayo Akinyola, Professor Olayinka Tilola, and Dr. Olusesan Olufolabo. Okay. Can you open the lights? So, kindly signify if you are in online, if you are doing online on Zoom. If you are making your presentation online, kindly signify in the comment section on Zoom so that the logistics can be appropriately sorted prior to your presentation. Thank you very much. Someone needs to call Dr. Lawal.
I'm presenting. You are good, Abby. I'll just second someone else.
So presenter one should get ready. Prevalence and correlates of domestic violence among patients with severe mental illness in the hospital setting in Lagos, Nigeria. Should get ready. We'll call you in a short while. Just a reminder, presenters have 7 minutes. For the first 5 minutes, you're allowed to reel your presentation. 2 minutes to the end of your presentation, you'll be given a notification to give you enough time to round off your presentation. And then once your presentation is done, you'll be given another notification. And I believe time management is also part of so all presenters should kindly take notes. Just waiting a few moments for the judges to give us a nod to go ahead. just for continue, I know the presenter for the first presentation is around. Is the presenter for adverse childhood experiences, negative social comparison around? Please just signify by raise of hands. Is around too. Okay. Predictors of early onset depression among young adults. Is the presenter around? No, we just want to know that you're around. We're not calling you yet. Okay. With a show of hands, barriers to mental health service utilization in Sokoto State. That will be online. Can we check? Barriers to mental health service utilization in Sokoto State. Check the online on Zoom. Okay. Psychosocial correlates of depression and suicidality. Okay. Around. Pattern of clinical presentation and determinants of clinical response in patients with first episode psychosis. Is person around? Okay. Okay, so we just need to clarify for the research work done in Sokoto. Okay, so I believe we are good to go. Our panelists are ready. Okay, so we'll call on the first presenter. She'll be presenting on prevalence and correlates of domestic violence among patients with severe mental illness in a hospital setting in Lagos. Thank you very much.
Good day, everyone. My name is Adola Pedro, and I'm here today to present prevalence and correlates of domestic violence among patients with severe mental illness in a hospital setting in Lagos. But before I proceed, I would like to acknowledge my teachers, and I also like to stand on existing protocol. Yes, thank you for this privilege. So, is there a slide? Oh, all right, thank you. So by way of introduction, I would like to define domestic violence as any act of physical, sexual, or psychological abuse and control by an intimate partner during an individual's life. This definition by WHO has been expanded to include any sort of violence within the family setting. And we all know that domestic violence has become a major public health concern globally, and due to its long-term consequences. Being diagnosed with severe mental illness, like schizophrenia, bipolar disorder, has been associated with increased risk of being a victim of domestic violence. And systemic review has revealed that up to 1 in 5 female and up to 1 in male patients with severe mental illness have experienced domestic violence at one point in time. In Nigeria, the prevalence of domestic violence against females with schizophrenia is said to be 73%. This is a study done by Afe et al. Sociodemographic factors associated with increase in domestic violence amongst this group of patients include being female, being single or divorced, and exposure to stressful life events. Clinical risk factors are and the number of symptoms, which includes frequency of hospital admissions, non-response to medications, and having a mental illness for more than 5 years, has also been linked to being a victim of domestic violence. Despite the pronounced burden of domestic violence amongst these individuals, the focus of research has often been on violence perpetrated by them, rather than being victims of domestic violence by others. The existing literature on domestic violence perpetrated against individuals with severe mental illness are mostly from Western countries. The studies reporting the risk factors are also few, and some have reported contrasting findings. There is thus a need for us to investigate the burden of domestic violence, its perpetrators, correlates among patients with severe mental illness in developing nations like Nigeria. The aim of this study is to determine the prevalence and correlates of domestic violence amongst patients with severe mental illness attending the outpatient clinic at the Federal Neuropsychiatric Hospital in Yaba, Lagos. And the study objectives are to determine the prevalence of domestic violence, the perpetrators of domestic violence, and also to assess the socio-demographic factors and clinical factors associated with domestic violence amongst this patient group. The research setting was the outpatient of the Federal Psychiatric Hospital in Yaba, and the study population were adults with severe mental illness. This includes anyone with a diagnosis of schizophrenia, unipolar depression, or bipolar disorder. The methodology area includes people who have a diagnosis of severe mental illness based on the ICD-11 diagnostic criteria, and patients between the ages of 18 to 60 years, patients who have duration of illness at least 2 years, and who gave their consent to be part of the study. While the exclusion criteria include patients with illnesses that were severe enough to prevent such an assessment or such patients from being part of the study, participants with severe communication problems, and patients who have comorbid mental health disorders or medical conditions. For the study design, it was a cross-sectional study, and a total of 180 patients were recruited into the study. A systematic random sampling technique was used, and we had about 9 patients at every clinic. The ethical approval was obtained from the Research Ethical Committee of the Federal Neuropsychiatric Hospital, Yaba. For the data collection, at every clinic day, once the patients have been recruited, MINI is administered to confirm the diagnosis. Also, the social-demographic and clinical information were collected using a pro forma developed by the research team. PANS, the Hamilton Depression Rating Scale, the Young Mania Rating Scale were also administered on these patients to determine the severity of their illnesses. The data analysis was done using the chi-square test to determine the association of the categorical variables, while Mann-Whitney U was used in determining the association between non-continuous variables and domestic violence. Multivariate regression analysis was also carried out to determine the variables that were significantly predictive of domestic violence amongst patients with severe mental illness. And the level of significance for this study was set at less than 0.05. So for figure 1, we can see that the prevalence of domestic violence perpetrated against, that's slide 20, perpetrated against patients with severe mental illness, we can see that it's 54% amongst this patient population. While the perpetrators of domestic violence were mostly their spouses and their siblings. For table 1, being married, marital status, move to the next one, please, and being employed as a manager was significant. I can't get my slides again. So for table 2 and 3, I don't know. Can you please show me table 2 and 3? So for table 2 and 3, we can see that this shows the clinical correlates of domestic violence against patients with severe mental illness. And we can see that severity of illness, the duration of illness, are significantly related to being a victim of domestic violence. I can't see very well on this. Sorry, I just lost my slides here. I don't know what happened. Is it back? Table 4. As shown in table 4, we would see that none of the correlates were predictive of domestic violence amongst this patient population. For the discussion, the prevalence of domestic violence among patients with severe mental illness in this study was 46%, whereas we have majority as being female. The prevalence is lower. This prevalence is lower than the prevalence of domestic violence reported as 75 among female patients with schizophrenia in the southwestern part of Nigeria. This was a study I mentioned earlier. However, we can see that this falls within the 30 to 50% prevalence of domestic violence perpetrated against psychiatric patients reported in systematic reviews. And the lower prevalence in this study is reflective to the finding by Affair and colleagues, maybe because their study focused mainly on female as compared to male and female, which this study focused on. This study also found that the most prevalent perpetrators of domestic violence were spouses, followed by siblings. These findings agrees with the report that intimate partner violence is the most common form of domestic violence, with a global prevalence of 26 to 28% among women and a prevalence of between 29 to 78.8% across different geopolitical zones in Nigeria. A previous study also reported that relatives are the second highest perpetrators of domestic violence, which is also in agreement with the findings in this study. This study, significantly more people who were married and more people who were separated or divorced were also victims of domestic violence within the family setting. This is in keeping with a study done in Ethiopia. However, a previous study that investigated intimate partner violence towards women with severe mental illness reported no association between marital status and intimate partner violence. This could be because the study only examined intimate partner violence only. Yeah. While employment status was not associated with domestic violence in this study, working as a manager was found as a correlate of domestic violence among the study population. There have been inconsistent reports in previous studies on the association between employment status and domestic violence. Yet, no study was found assessing the association between the type of occupation and the domestic violence amongst patients with severe mental illness. This finding in this study is thus a baseline for further research. In this study, older age at diagnosis was outcome of this study also reveals the need for a high index of suspicion, screening and prompt intervention for patients with severe mental illness experiencing domestic violence, and the need for relatives to be educated and supported when needed. Thank you for listening.
Thank you very much, man. That was a very spirited presentation. So, just a reminder. Just a reminder to our presenters that we have 7 minutes for our presentation. I will call in on shortly, in fact right away, the presenter for adverse childhood experiences, negative social comparison, and body image dissatisfaction as predictors of early onset of depression among young adults. A round of applause for him, please.
Thank you very much. Good afternoon, Mr. Chairman, sir. All protocol duly observed. Adverse childhood experiences. Well, our group, I represent the psychology group, one of the psychology groups, and our group is actually interested in looking at the contributions of adverse childhood experiences, negative social comparison, and body image dissatisfaction as predictors of early onset of depression among young adults. Well, we all know that quite a lot of causes have been alluded to depression, and we don't want to bore you with that. But our group looked at some current trends, especially among young adults, related to certain factors that we observed in the environment. We looked at issues with adverse childhood experiences, which have been in existence. Well, these are events, traumatic experiences that the individual go through during early life. We looked at also negative social comparison, as well as negative body image, and how this can actually have effect in leading to depression. So, okay, wow. Okay, are we ready now? Slide. Okay, let me go to slide 4. And one of the reasons we're actually looking at also as depression is that in as much as about 280 million worldwide are infected by this particular condition, and it is expected to even be growing more, the age gap between age 15 and 30 has actually been indicated with having one of the highest contribution to that statistic. And a particular study that was conducted not too long ago found out that about 32% among Nigerian undergraduate students actually have one form of depression or the other. So we're looking at both negative social comparison. We are looking at body image dissatisfaction as well as adverse childhood experiences. Our major objective was to look at the primary to investigate the predictive abilities of adverse childhood experiences, negative social comparison, and body image dissatisfaction on early onset depression among young adults. And we set 4 objectives: to examine the role of adverse childhood experiences, to explore the role of negative social comparison, as well as assess whether body image dissatisfaction will predict early onset of depression among young adults. We also wanted to find out, to determine the combined predictive effects of adverse childhood experiences, negative social comparison, and body image dissatisfaction on early onset of depression among young adults. So we formed 4 hypotheses, and these are hypotheses. In terms of methodology, it's a cross-sectional study and using purposive sampling techniques. The research actually was carried out within Federal Neuropsychiatric Hospital Yaba, and participants were aged between age 18 to 26 with the diagnosis of depression. We used standardized instruments, which are actually the psychometric properties were actually established in a pre-study that we carried out, and we used about 4 of them on our participants. Now to the results. Okay, you can see the distribution of the age there. Majority of the participants were aged between 18 and 23. Almost about 95% of them, and majority of them were also female. Next slide. There, for hypothesis 1, we said adverse childhood experiences will significantly predict early onset of depression among young adults. And we actually found out that, yes, adverse childhood experiences contributed about 48% to the variance leading to the early onset of depression. And we can see there by the beta that for every unit of adverse childhood experiences, the unit of depression increased by about 2.3%. The hypothesis 2 also contributed about 31% of variance to the predominance of depression, and contributing factor that for every increment in negative social experience, there was about half increase in depression. Next slide. And for the body image dissatisfaction, contributed about 50.1% of the variance. And for every unit of body image dissatisfaction, the depression increased about 1.4 times. Next slide. The next slide will show about the combined role of all these factors. They contributed about 64% to the variance of depression amongst young individuals. So this result, this is all confirmed most studies that have been carried out, and in terms of our own recommendations, what we concluded by saying that adverse childhood experiences, negative social comparison, and body image dissatisfaction are all significant predictors of early onset depression among young adults. And body image dissatisfaction had the strongest independent effect of about 50% on early onset depression, followed by adverse childhood experiences and negative social comparison. This result also underscored the multifaceted nature of depression and suggested that it is influenced by a complex interplay of early life experiences and cognitive factors such as self-comparison and body image concerns. The implication of this finding suggests that that mental health interventions targeting young adults, given the significant impact of adverse childhood experiences on early onset depression, so early intervention programs that focus on trauma-informed care are crucial. Thank you very much for listening.
Thank you very much, sir. That was just right on time. The next presenter is online from Sokoto, right? So our next presenter is from Sokoto, and you'll be talking on barriers to mental health service utilization in Sokoto State. So you can unmute, sir. You have 7 minutes for your presentation. Your slides are being projected here also. Can you start talking, sir?
Hello, sir.
We can hear you.
Yeah, thank you very much. I can see my slides now. Good afternoon, ladies and gentlemen, teachers and senior colleagues and colleagues. My name is Ahmad Abubakar. I will be presenting on barriers to mental health service utilization in Sokoto, Northwest Nigeria, on behalf of my colleagues. Next slide. Yes, so this is the outline I will want to follow. This is the outline. Hello? Hello, sir. Can I go ahead? Hello, sir.
You can go ahead. You can go ahead. You can go ahead.
All right, thank you very much. So this is the outline, starting with background and down to conclusion and recommendation. Next slide. Yes. So our introduction, barriers to mental health service utilization remain a problem. The physical, cultural, or financial. They are more common in lower and medium income countries where about 80% of population lack access to mental health services. Next, a majority of people in low and medium income countries usually patronize out-of-pocket payments. So this poses a lot of burden on the society. And we know that about 25% of world population may suffer a form of mental disorders at one point in their lifetime. In Nigeria, stigma has been a serious problem, you know. We found honest mental disorders we do see. This was in 2020. Next. Next slide, yeah. And we all can remember that the longer the duration of untreated mental
I think we're having a network glitch.
So the method we studied, it was a cross-sectional study involving 52 psychiatric outpatients and 99 relatives. The study was spread across two psychiatric facilities, Federal Psychiatric Hospital, Paris, and Usman Empori University Teaching Hospital. It was a semi-structured interview administered questionnaire. The sample size was calculated using formula for the script study, and we came up with a sample size of 151 individuals, which we studied. Next, okay, this is the methodology continued. Data was analyzed using SPSS by SHIM25. Chi-square was used to assess the statistical association between the variables. P-square of less than 0.05 was considered significant. And this is the ethical approval number we collected from Udut, Sokoto. Next. This is the inclusion criteria. Patients should not be overtly psychosis. They should be about 18 years of age or older, and they should be attending, assessing their care in either Udut or Federal Psychiatric Hospital, Paris. Relations and responsible relations of patients must have consented for the studies. And the exclusion criteria involve general medical condition as comorbidity. Next. 151 patients were studied. Their mean age was 37.9, plus or minus 12.6 years. Modern age was 41. Majority were males. Majority were married. Literacy level was at 39.7%. A sizable number was self-employed, and about 65% have no community support. Next. Two-thirds of patients lack access to mental health services. A majority have financial constraints procuring their medications. Average income of the participants was about 50,000 naira per month. We found cultural and financial barriers to be significantly associated with mental health service utilization. Yes, next. So in conclusion, this study found cultural and financial barriers as the major barriers to mental health service utilization in Sokoto, Nigeria. And we recommend the need for public, we recommend increase in public enlightenment and advocacy in favor of patients with mental disorders. And we also recommend increase National Health Insurance Scheme utilization to reduce out-of-pocket payments. Next, thank you very much for the audience for sharing.
Please kindly ignore the Yoruba translation of thank you. The most important thing is that we all understand. Thank you very much, sir, for that presentation, and thank you for fighting through the technical glitch to get that done. We'll be moving on to the next presentation, which is the psychosocial correlates of depression and suicidality among people living with spinal cord injury in a tertiary hospital in Lagos, Nigeria.
Okay. Everyone, my name is Adedoku Homa Okuchi. I'm here to present my work titled Psychosocial Correlates of Depression and Suicidality Among People Living with Spinal Cord Injury in a Tertiary Hospital in Lagos, Nigeria. As a background, spinal cord injury is a medically complex and life-disrupting condition. It refers to damage to the spinal cord from both traumatic and non-traumatic causes. It occurs globally, and the prototypical physical complications of spinal cord injury that could found in spinal cord injury include impaired respiratory function, increased risk of pneumonia, atelectasis, neurogenic bladder, neurogenic bowel dysfunction, sexual dysfunction, amongst others. Next slide. Now, spinal cord injury is also associated with some psychological complications, which include depression, anxiety, post-traumatic stress disorder, substance abuse, and suicide. Now, a depressive disorder is characterized by persistent low mood, diminished interest in previously pleasurable activities, impairment in cognitive function, such as sleep and appetite. Now, depressive disorder often worsens the crippling effect of physical conditions. Now, patients with spinal cord injury are susceptible to depression because of the continuous pain that they are subjected to, the poor quality of life, and impairment in functioning, which they also experience. Now, furthermore, depression among spinal cord patients with spinal cord injury is a common cause for suicidal behavior. Next slide. Suicidal behavior encompasses suicidal ideation, suicidal plan, suicidal attempt, and then completed suicide. Now, there's an abundance of information on spinal cord injury. However, there is still research gap in terms of depression and suicidality among people living with spinal cord injury. Now, my studies sought to generate data for the assessment of the prevalence of depression and suicidality in people living with spinal cord injury. Now, part of the importance of this study is that the findings from this study population. Next slide. Now, aims and objectives. The aim of this study was to determine the prevalence and the psychosocial correlates of depression and suicidality among patients living with spinal cord injury at National Orthopedic Hospital, Ibobi, Lagos, Nigeria. Now, I go to the objectives. Number one is to determine the prevalence of depression and suicidality among people living with spinal cord injury. Number two, to determine the social demographic correlates of depression and suicidality in patients living with spinal cord injury. Number three, to determine the clinical correlates of depression and suicidality in patients living with spinal cord injury. And number four, to determine the psychological correlates of depression and suicidality among spinal cord injuries. Next slide. So for the method study setting, it was carried out at the outpatient clinic of the spine unit at the National Orthopedic Hospital, Ibobi. For the study participants, it included adult patients with diagnosis of spinal cord injury. For the eligibility criteria, for inclusion criteria, the patients 18 years and above, they had to have diagnosis of spinal cord injury made by a consultant orthopedic surgeon and confirmed by a magnetic resonance imaging. The patients had to be able to communicate in English, and they also had to give their consent to the study. Next slide. Next slide. For the exclusion criteria, it involved if a patient had a previous history of mental illness before the diagnosis of spinal cord injury, or if the patient had a severe illness that was going to impair proper assessment. The study design was that of a cross-sectional pattern. For the sample size determination, it was done using Kish formula for the determination of sample size in a cross-sectional study, giving rise to a total of 246, which was corrected using Hartman formula to a total of 123, because it wasn't going to be possible to get that number of patients based on the seen in that hospital. Now, for the sampling procedure, this was done by simple random sampling by ballot method, in which the patients with the diagnosis of spinal cord injury who also met the eligibility criteria constituted the sampling frame. The number of patients fixed at six equal the number of yes ballot papers in the ballot box for each day. So we were able to get 6 patients per day. For the study instruments, it included social demographic and clinical questionnaire, Beck's depression inventory 2, Rosenberg self-esteem scale. Next slide. The Beck scale for suicidal ideation. The 3-item concise version of the alcohol use identification test, and the brief version of the World Health Organization quality of life. Next slide. Now, the data was entered into the statistical package for social sciences version 26, and some of the results are seen on the slide. So this result shows that most of the patients that were involved in this study were old patients with a median, elderly patients with a median age of 58.8. And then it also shows that females were more affected in this study. This shows the prevalence of depression. Next slide. Prevalence of depression that was found was 21%. Next slide. Now, of the components of the suicidality, only suicidal ideation was significant in this study, and the prevalence of suicidal ideation was 15%. Next slide. So for the discussion, for objective 1, the prevalence of depression in this study was found to be 21%, and this was in agreement with a meta-analysis that was done by Williams and colleagues, which found the prevalence of 22.2%, and a community-based study in North America by Kruger and colleagues, which found the prevalence of 20 to 30%. However, it was in contrast with the studies done in Asia by Mandira and colleagues, which found a higher prevalence of 84.3%, and another done in Kenya by Kaguchi and colleagues, which found the prevalence of 70.2%. Now, the difference in this could have been because of differences in study setting and study instruments. Still on objective 1, the prevalence of suicidal ideation was found to be 15%. This was in tandem with some studies that were done in the United States, but contrasted with a Korean-based study by Name and colleagues. And the reason for this could have been because of prevalence in sample size. For objective 2, gender was found to be associated with depression, and this was in line with a study done by Cruz and colleagues. However, it was in contrast with a study done by Bombardier and colleagues in 2004. Also in objective 2, occupation was also found to be significantly associated with depression in spinal cord injury, which was in agreement with a Nigerian work done by Baduri and colleagues. Next slide. For objective 3, no clinical factor was found to be significantly associated with depression in spinal cord injury, and this was in agreement with Bombardier and colleagues. Note that this implies that having the diagnosis of spinal cord injury is significant enough to make a person come down with depression. Also, previous chronic medical illness was found to be associated with suicidal ideation in spinal cord injury. For objective 4, self-esteem, physical and psychological domains of quality of life were found to be significantly associated with depression, and this was in line with the study done by Kraft and colleagues. However, it was in contrast with that done by Mosavi and colleagues. Furthermore, the severity of depression and self-esteem were found to be significantly associated with suicidal ideation in spinal cord injury. However, only severity of depression was predictive of suicidal ideation in spinal cord injury. Next slide. So for the strength, the chance of selection in simple random sampling technique, it utilized instruments, and the findings could serve as a comparison for future studies, especially in this environment. For the limitation, the study being a cross-sectional study is only able to provide correlates but not causality. And also because it's a hospital-based study amongst the outpatient it may not be generalizable to patients on the ward and to the general population of people with spinal cord injury. So in conclusion, depression and suicidal ideation are common in people living with spinal cord injury. Thank you.
Thank you very much for running us through that. We'll go to the final presentation for this session, and it's the pattern of clinical presentation and determinants of clinical response in patients presenting with first episode psychosis. Round of applause for Ash. Comes forward, please.
All protocols duly observed. I'm Dr. Kopola Oluwasunbotoyin, and I will be presenting a paper titled The Pattern of Clinical Presentation and the Determinants of Clinical Response in Individuals Presenting with First Episode Psychosis. The authors are myself, Dr. Adebayo Hare, Dr. Motojesi M.O., and Dr. Shofa Konju-T.O. Next slide, please. Background: psychosis is a debilitating illness characterized by disruptions in perceptions and thought process. It is a major component of most psychiatric illness, and it affects about 13% of the Nigerian population, and is often complicated by functional impairment and a higher risk of suicide than in the general population. First episode psychosis is particularly distressing given its young age of onset, and that it is often associated with denial and a tortuous pathway to care, due to poor understanding of its etiology and, more important, the pattern of symptom presentation. In psychotic disorders, early clinical response prevents the persistence of symptoms, and it is associated with the prediction of remission in later months. Therefore, early identification of probable non-responders is the first step towards enhancing therapeutic actions and will benefit this susceptible group. This is especially so in the context of first episode psychosis. And the general aim of this study is to determine the pattern of clinical presentation and the determinants of clinical response in individuals presenting with first episode psychosis at the Federal Neuropsychiatry Hospital, Yaba. And the objectives are: 1, to determine the pattern of clinical presentation among patients with first episode psychosis, to determine sociodemographic factors associated with response in first episode psychosis, and to determine clinical factors that are associated with response in patients presenting with first episode psychosis. So the methodology. So this study was conducted at the emergency, the inpatient and the outpatient unit of the Federal Neuropsychiatry Hospital, Yaba, and the participants were individuals with first episode psychosis. The inclusion criteria were patients aged 18 and above, and patients with a diagnosis of first episode psychosis, and was confirmed with mini international neuropsychiatric interview. So the exclusion criteria were history of a psychotic disorder, previous antipsychotic use, patients with cognitive deficit who were unable to understand or respond to the questions, and patients that were too ill to participate. And the study design was a longitudinal prospective study. The sample was 192, and the sampling technique was a simple random sampling technique. The instruments used were the sociodemographic questionnaire, the positive and negative symptom scale of schizophrenia, the mini international neuropsychiatric interview, the Oslo social support scale, and the WHO disability assessment schedule, item 12 version. Ethical approval was gotten from the research and ethics committee of the hospital, and the results as this: the objective 1, most of the participants who presented with first episode psychosis were young adults. At least about 2/3 of them were young adults. There was almost an equal gender distribution. However, we have more males than females. So the common diagnosis was schizophrenia. About 3 in 4 of the participants presented with hallucination, then delusion, and more than half had some degree of hostility. Of the delusions, the commonest was persecutory delusion, and nearly 70% of the participants had a negative symptom. The poor judgment and insight was found in 8 out of 10 participants, and about 75% of patients had functional impairment. With objective 2, which was to between sociodemographic factors and clinical response. So there was no sociodemographic factor that was significant response at 6 weeks among the participants. Objective 3, clinical factors associated with response. Response at 6 weeks was found to be associated with early response at 2 weeks and medication compliance, and this remained so with multivariate analysis. And this is the logistic regression table of factors associated with response at 6 weeks, so that compared with poor drug compliance, individuals with greater than 80% drug compliance were 5 times more likely to have respond better to treatment. Next slide, please. So in conclusion, first episode psychosis has an almost equal gender distribution, commoner in adolescents and in young adults, and its onset declines with increasing age. Early response at 2 weeks and greater than 80% drug compliance were associated with good clinical response. The strength of this study was that it employed a longitudinal follow-up study to investigate the determinants of response, which offers a higher level of evidence than the snapshot observation or doing a retrospective study. So the limitation of this study was that it was conducted in one location and may not be representative of the population with first episode psychosis. The study only measured clinical response and did not assess improvement in functioning, which is also a factor in considering outcome. So the recommendation was for an early intervention in psychotic services to be instituted to address the mental health issues of this susceptible population, which was more common in youth. Thank you.
Thank you very much, ma'am, for that presentation. So at this point, we've come to the, we've completed all presentations for this breakout session, and we'll open the floor for questions and comments for the presenters. Any questions to clarify what was presented from the floor? Okay, sir.
Thank you so much for the beautiful presentation. I was just interested when I saw 70% of first episode psychosis having negative symptoms. How would you explain that?
Okay, yes, the question is for the fifth presenter. Yes.
Thank you very much, sir, for the question, sir. So we use the positive and negative symptom scales of schizophrenia to rate the severity of the negative symptoms and also the positive symptoms. So for the negative symptoms, we found out that about more than 70% of patients had negative symptoms. That's asociality, I know that. Yeah, so about 70% of them had it. And we were saying that this is one reason why it is that they don't present early, because they are not identified early in the family. So until they come to the hospital, and then the family says, oh, this started 2 weeks ago, and then we take an history and realize that, oh, these symptoms that I was presenting with, it was not really puberty. They were just negative symptoms of schizophrenia that were not picked early. So as much as 70% of the patients we saw had negative symptoms.
Question is, in the UK, we have the AIS, Early Intervention for Psychosis team. And this is why they set up the team. They will have gone out to, anyway, the contest is different because the family doesn't need to pay, but the team will go out looking for these people. So there has been a period that these patients have been suffering before they even came in contact with you. Thank you.
Thank you, sir.
So thank you very much. We were just discussing what is the duration of the illness, the start, and when they eventually present. So I think you need to give us an idea of that. Yes. Yes, but you say.
We did the DUP because one of the clinical factors that we are trying to associate with response, but it was found not to be, there was no association between DUP. And I think, except I checked the main book, I think it was about 22 weeks. I'm not so sure. Please, I will check back in like few seconds and I will give you back.
Thank you very much, Dr. Popola. I think we're having last presenter effect, but I was expecting questions for the first presenter who presented on domestic violence also. I was expecting very interesting questions because of the findings also. Now we are shying away from talking about being a protective factor in mental illness, and I think they pointed that out.
Thank you. So my question and observation has to do with the presentation from the presenter on spinal cord injury. So I look critically into that result, the finding, the conclusion, as well as the recommendation. So I look at it that what is actually the clinical relevance of that research. Individuals with spinal cord injury, basically they are already going through distress. Now you also found out there was suicidality in them and probably low self-esteem or something of that nature. You do not address how you plan in the context of recommendation to manage this situation in those patients. It was a big gap that was not addressed in that recommendation. So for me, that was why I want to ask, do you think there is a need to actually address that, or what exactly are some of the clinical relevance of that result in helping those individuals, at least to minimize the psychological distress that they may be going through? Thank you.
Thank you very much. Okay, I think that's for Dr. Adedokun. Okay. Any other questions for Dr. Adedokun? For the fourth presenter? Okay.
Okay, thank you very much for the question. I had recommendation in my work, but because of trying to constrain myself to limit myself to the number of slides that were given to us, I didn't put it there. So depression is common in physical illnesses, and especially illnesses that are chronic in nature. So the relevance of this study is to be able to find out the burden of depression and suicidality among this population, and to be able to know what to do to be able to help them live their lives better. Because as we know, there are some things that are unavoidable. Nobody would know that, nobody would want to position his or herself in that will cord injury. So if a person has spinal cord injury, then, and it is chronic in nature, there should be something that should be done to be able to get the person live better. So part of the recommendation would include that there should be regular screening for mental illnesses among this population, and then there should be prompt referral to psychiatrists for people who meet diagnosis of depression or suicidality, so that they get prompt treatment. And then, because this is a study that's in a consultation liaison area, it will be good for a psychiatrist to be incorporated in the management team, those working in orthopedic centers, and hospital settings to prioritize policies that will favor assessing or screening for mental illness. Finally, this study for in this study. Thank you.
Thank you very much, Dr. Adedokun, for the answers provided. We have questions and comments online also. This comment is from one of us here. Sorry, can you help me scroll it? Dr. Tayo Lashebikon, and it's directed at Dr. Akin Gabriel. Said, thank you, Dr. Akin Gabriel, for your presentation. From the onset, your objective was to look for prediction and not association. We know the limitations of cross-sectional studies, even with both linear and logistic regression. I know how difficult a cohort study may be in our environment, but maybe we can consider a method where the cases have early onset depression. This can help better with prediction. That's the comment. The question is, what was the R2 for the linear? Oh, sorry. What was the R square for the linear regression? It would be nice to know how much of the variance can be explained by all the factors considered and how much we still need to look for other factors to complete the model. Hope you got the question.
The person who made it, Dr. Lashibekon. Yeah, I think we actually mentioned the result of the linear regression, the R square. Said that for the adverse childhood experiences, it was 40.8%. That's about adverse childhood experiences explain about 40% of the variance. Then for the negative social image was 30%, whereas the body image dissatisfaction was 50.1%. In combination, the three actually combined to predict early onset depression to about 62%. Other factors could be responsible for the contribution to the so 48%, 32%, and 50.1% are the to the extent to which each of these factors will predict early onset depression in the population.
Thank you very much, Dr. Akin. Okay, we still have other questions from the audience. Any questions for or comments for our presenters? I want to move to the panelists. Do the panelists have any comments or questions? So the results have been computed. Shortly we'll be rounding up. Joining us, and then the other court will be joining us shortly, and they will move on to the announcement of the result and the presentation of awards, and then we'll round off with thanks and photo sessions. So we'll take 5 to 10 minutes interlude for people from the other cohort to join, and then we'll round off the research fair for 2024. Thank you for your patience. So we just need to exercise patience a little longer, just for a few minutes. The results are being compiled at the other hand also, and they will join us shortly. We've waited this far, so let's hear the results. Some classical music, please. Or some Afro beats. Okay, let's have some Afro beats. Something for some high life, not something for some Obey or Sonia Day or Oliver the Coke.
halẹ̀ halẹ̀ kò lè halẹ̀ mọ́ mi rárá mo ti lálàfẹ́ èjì mo lọ́lùwà ọ̀rọ̀ mi lọ́wọ́ Olúwa ló wà.
àyìnbásíkò ló làwọn ẹ̀dá o ọ̀rọ̀ mi lọ́wọ́ Olúwa ló wà.
halẹ̀ halẹ̀ kò lè halẹ̀ mọ́ mi rárá. Mo ti lálàfẹ̀yìntì mo lólúwa. Ọ̀rọ̀ mi lọ́wọ́ Olúwa ló wà.
Àìmásìkò ló ra mú ẹ̀dá o. Ọ̀rọ̀ mi lọ́wọ́ Olúwa ló wà.
Gbẹ́dọ́gbẹ́dọ́ fẹ́ fi di ọ̀gẹ̀dẹ̀ gbẹ́. Kí látẹ́gùn fẹ́ fi di gẹ̀dú ṣe. Ọ̀rọ̀ mi lọ́wọ́ Olúwa ló wà.
Àìmásìkò ló ra mú ẹ̀dá o. Ọ̀rọ̀ mi lọ́wọ́ Olúwa ló wà.
Ẹni rówó he lójú àlá tó ń dunnú. Ẹni kò tẹpá mọ́ṣẹ́ ẹ̀ nítorí ebi. Ọ̀rọ̀ mi lọ́wọ́ Olúwa ló wà.
Àìmásìkò ló ra mú ẹ̀dá o. Ọ̀rọ̀ mi lọ́wọ́ Olúwa ló wà.
Ẹni rówó he lójú àlá tó ń dunnú. Ẹni kò tẹpá mọ́ṣẹ́ ẹ̀ nítorí ebi.
you know, when you want to announce results in Nigeria, there's quite some apprehension because they are lobbying and politicking. But we can assure you that this is a scientific balance, and there is no such here. There is no lobbying, there is no politicking as regards results. Then for those that watch a reality TV show, when they want to announce the result, they'll say these results were verified by Deloitte and confirmed for those who watch that reality show. So the results are coming in already. Wow. I can see very beautifully designed plaques already coming in. So, just to bring us up to speed, where we are on the program is at the announcement of results and presentation of awards. So,
Okay, I just want to say a brief thing and to thank everybody for this very fascinating and wonderful engagement for a scientific session. First, we want to know that we have award in 4 different phases. We have the first, second, third award for both parallel sessions. That is, for the parallel sessions here, for objectivity, we have award for the first, second, third. And for the other parallel session, at the other hand, TDC, we have first, second, third. Then we have a poster presentation. I will say a few things after the award on the poster presentation. Because we see that people are not really interested in having poster presentation. So we have some tag and some extra award for those that have poster presentation, including cash award. Yes, yes. And for that, we have our trainers, our teachers that continue to breed us, to groom us, to train us, to make us a better individual. So now, they have given us some special incentive in form of award that we tag for the poster presentation. So the 4th phase of the award has to do with recognition of the outstanding guest speaker lecture that we have. A round of applause for our guest speaker. And annually, we intend to have resources to also gradually honor 1 or 2 of our founders, our trainers. So for this year, we have award for our founder that has given us a seed grant or a seed incentive to help us with this research. And the other one we will hear when we get there. Thank you very much. So for the 4-second tour here, my Ogaye, Dr. Akinola, Thomas smile all the time, will be the one anchoring that for us. Ogamima.
Thank you very much, Dr. Bello Majid. I believe we've had a good time so far. So, please, sir, our guest speaker will actually give out the award. So for the sessions here, the third award goes to okay, 2 seconds. So no third. So that means group 4, that's prevalence and correlates of aggression in acute care wards of Nigerian Psychiatric Hospital. Should come out. That's group 4. That's forensic, I think. Then cognitive insight and its role, that's psychology department. So the two of them tie the two groups. This group 4. Prevalence and correlate of aggression. Stand beside him. Thank you. So where is psychology department? Who's going to collect for them? You come and stay beside him. Flank him on both sides. Since it's a tie. Okay. Stand there so that I will.
Okay, so any of them. Okay, you came out first. So congratulations. Congratulations. Well done. Very well done.
You won't take picture with our fingers. What's your problem?
Good. Congratulations for a very good presentation.
So the first position, first award goes to, that's sleep disturbance, social support, and functioning in patients with bipolar disorder in Nigeria. Oga and Omoshe, well done. Well done.
Congratulations, congratulations. Well done.
Thank you, sir.
Okay, you hold it. Great team. Well done.
Thank you, sir.
Okay. So, Dr. Additional.
So is that okay
Yes,
then?
sir.
Thank you very much, Ma. I'm also proud that my president, the president of the ARD, is part of the winning team. So the TD results. Okay, the TD result is on its way, but we want to assure you.
When we are waiting for the TDC, do we have all the poster presenters here? So we wait for them.
Just
Move to the third phase. No, the fourth phase now. Honestly, this last phase is really sweeting me. Oh. I don't know about you. Oh. Because you see, when we appreciate our founders, our elders, it brings so much joy. You know, like we were told that all the time when we see our, our parents, we have this feeling. But I know that by the time we have more resources, we will begin to appreciate quite a number of our elders. But for today, we will appreciate our guest speaker and our chairman, our Bashorun Bashegun of Ibadan Tileto Ko. Will be the one to help us to give them the award. Yes, sir. Yes, sir. You will help us to give awards, sir. Yes, sir. So that yes, sir. So that gradually for the guest speaker, right? That's the one for the guest speaker. Did you check? Okay. So for our guest speaker now.
This is great. I'm really honored and impressed because I believe that I think this is the greatest honor and privilege I've ever had in mental health. Since I started presenting an award to no other person.
Yes, sir.
Then I think this is. I'm still repeating myself. Because you see, we have come a long way in this profession. And we thank God that God has kept us alive. Allahu Akbar. Allahu Akbar. To be able to say that I'm alive to see today. And to thank my people here for the privilege, I say again, of inviting me to be in charge of this program and to present this honor, laudable honor, to no other person than my friend, my compatriots, my comrade, my professor, Alhaji Maruf Adeleke, who has improved himself so much in life. He mentioned in his profile from the time he was at Aroloya, from Aroloya in Lagos, downtown, to the pinnacle of WHO, to United Nations, and then back to Manchester. And then at 70, retiring briefly, not finally, from mental health practice. I think it's a great honor and privilege. I want to thank you all for keeping me up to this time to sit down to present this. Please show your face. Let them see you. Papa 70. Papa 70. You see, we have been looking forward to people who will replace the likes of Professor Adi Lambo, Professor Yobiditi, and so on, and so many of them that have gone beyond. Mama Dr. Johnson, Olija, Maloma, and the rest. Now we are seeing everyday people today, and I pray that you will live long. As you get this award, this will not be the last. You are going national because Gureje has got national. It's your turn. May God bless you.
Thank you.
Allahu Akbar. Please, camera, please. Come in now. Come over. Very good. Very good.
Thank you. It's fine.
It's fine.
Can I just say something, please?
Yes, please.
Thank you so much for this opportunity. It is okay. I want to say again, like we say in Islam, Laula wala quwwata illa, that I have no power, I have no wisdom, except that which comes from above. So I thank you. I thank all the management, my friends, my colleagues from all over the country and the UK. I thank everybody. I want to make a little contribution of 1 million naira towards the project, so that you can increase the amount of money you give to researchers. And inshallah, bi kudratullah, we might be able to make more later. Thank you so much. Thank you.
Thank you very much, sir. Thank you, sir. Yes, sir. Thank you very much, sir. Thank you, sir. Well, I think because we have the result from TDC, so that our panelists, Dr. Hansui, sir, you will help us to give the award to the first, second, third from TDC, and my organ, Dr. Luani, sir. You help us announce the discourse, sir. Why Dr. Luani will give them the award. Dr. Antwi, Emma Bino Amomlara.
Yeah, while observing the already established protocols and not to waste, spend more time. We have spent a lot of time. I will quickly announce the winners of the presenters from the TDC group. Now, starting from the second runner-up, so to say. By the way, the quality of the most of the presentations are very, very commendable. Very, very commendable. I must say that. But of course, we must have winners. Somebody must emerge as the winner. So everybody has done very well. It takes a lot of time to be involved in research, collect the data, analyze, and then write up. And also coming out to do the presentation. So we say congratulations to all the presenters. But then the second runner-up is the group that presented the topic, which is the, it's not a group, it's actually the presenter from all the way from Calabar, Federal Neuropsychiatric Hospital, Calabar. That is the topic on pilot validation of the DSM-5 substance use disorder checklist among Nigeria by Dr. Ubong Udofia. Yeah. So please, let's a round of applause to him. He's not here physically. We need a representative. He presented virtually. Yeah, so. Okay. It was. I don't know whether it's still on. Yeah, okay.
Yes, on behalf of the medical director, the entire management staff of this hospital, the organizer of this edition, the seventh edition of this research fair, I want to say congratulations to Professor Obong Gabi, Dr. Obong, for being the second, Idofia, for being the second runner-up at this presentation today. Congratulations. It's being received by Dr. Ndionuka on his behalf. Thank you very much.
Thank you so much. So the second position goes to the topic, psychosocial factors predicting treatment adherence among patients with schizophrenia attending Federal Neuropsychiatric Hospital, Yaba. It's one of the psychological groups, and we know that they always do well. So let's give it up to them.
Once again, on behalf of the medical director, Dr. Olubenga Oweye, the entire management of the hospital, as well as the organizer of these, research fair, I want to present these first runner-up award to the psychology group for the year 2024 research fair. Congratulations on this award.
And here comes the winner. Number 1 position. And the group, is it from Yaba or outside Yaba or beside Yaba? We shall soon know. But they presented the topic, hematological and biochemical profile of children with cerebral palsy in a neurodevelopmental clinic in Lagos, Nigeria. No, C&A, yeah. Child and adolescent group. C&A group.
Was okay, mommy. Yogo. That's a grandmother. So once again, on behalf of the medical director, Dr. Olubenga Oweye, the management of this hospital, as well as the organizer of this research fair, year 2024, I want to present the Best Oral Presentation Award to the C&A group. For the best overall group, the C&A group. Congratulations this year. Congratulations to the entire team. We appreciate everyone. The Lord bless you.
Hmm? The same thing. As we are coming out, people are waiting. Yeah. So we also have poster presentations. There are actually 3 posters presentations, but the judges were able to assess only 2 of them, not because the third one was not of quality, but unfortunately, as at the time the judges visited, there was no presenter. Nobody manned the position as at that time, and we were already being called. So we had to, that's the reason for it. It's unfortunate. But 2 of them were assessed, and the decision of the judges was to base our decision on that too. Yeah, so the poster with the topic Improving the Quality of Mental Health Discharge Summary at Federal Neuropsychiatric Hospital, Yaba, scored 65%, and the poster with the topic Tobacco Smokers' Knowledge of COVID-19 and its relationship with smoking behavior scored 60%. So improving the quality of mental health discharge summaries at Federal Neuropsychiatric Hospital, Yaba, is the winner of the poster presentation. Let's give them the award first. Let's give them the... Please, let's give it... Improving the quality of mental health discharge summary at the Federal Neuropsychiatric Hospital, Yaba. That's the winner. Yeah. Who is doing the presentation? Who is doing the... This is the only one. Is the only one? Okay.
A special distinguished award to be presented to General Okulate. General GT Okulate. GT. For this 7th annual Yaba Research Conference, it was really tough getting fund, and we wanted to give award. And we also wanted to encourage poster presentation. So when we were really having it very tough, and we were moving to people to support us, he said he has something in place for us, even when we didn't know. And he wanted the research committee members to decide how we will use it. That's how he put it. And he donated a sum of 500,000 naira to us. We really appreciate this, and we appreciate the ongoing tutoring. He's been with us for several years. Research class, physically, virtually, and in all ways, he's been with us teaching us. So we want to dedicate this award of distinguished award, and it will be given to him by our former medical director, our chairman, sir. He will help us. We will take picture with it. Anytime he's around, we can also take pictures. So thank you, sir. Dr. Amosu, please kindly.
I can remember very much. My namesake, Taiwo Benga. I hope you've seen it. Yes. I remember that we started together this project, and I appreciate him. I appreciate him so much. And also again, time has come again for this privilege and the opportunity to present this. Professor Maruf, please, can you join me, please? Because you see, we are now experiencing issue of philanthropy. Philanthropy in psychiatry. He is an advocate of social and social psychiatry and
it's
no.
ex-effect.
Apart from efficacy of it, what is important is marketing. You see, Dr. Okulate believes so much in social marketing and psychiatry. He's a product of late General Adilaja, who was his boss. I remember he was our president at the APN. Yeah. And General Adilaja actually tutored General Okulate. And Adilaja, may God put him in his right place in the bosom of the Almighty God. Believe so much in social marketing of psychiatrists. When I came from abroad, I saw psychiatrists in those days. They were not well dressed, ties and so on, so rough. And we decided that, well, a psychiatrist must have the best cars, must use nice pictures, nice frames, perfumes, and so on and so forth, so that it will attract younger generation to psychiatry. We don't have many people coming to do residency program, but when they see us, because in those days we had a senior colleague, Baba Benitez. He was riding a Citroen in those days. So when he brings his Citroen to Yaba, and the car goes up like that, of course, we younger doctors will say, I want to be like Ayo Benitez. He was smoking pipe. And you understand me? Yes. And so when Okulate now decided with Baba Adilaja, we said, okay, let us start social marketing and be looking at ourselves. We wearing correct costume, dresses, ties and bow ties. Many of you knew I was always in bow ties. You understand me? I was smoking anymore initially in those days. Yes. So I want to thank Benga Okulate for his love for psychiatry and mental health. He's a wonderful person. He knew my inadequacies as regards my programs too in those days. And he supported me. That was why he was always coming. On my behalf, I'm saying it, he would say, I must come. We must continue. We brought Professor neurologist from Lut. What is his name now? Professor Danesi. Danesi came in as a neurologist. We did an international program on neurology and so on in Yaba here, with the likes of Lut and so on. I went to Senegal for such programs too. But we thank God today that the elders and the younger generations are being recognized. God will also recognize you people. In your old age, you'll be recognized. In your old age, you'll be recognized. You will not live in penury. You will be prosperous. You will donate like Monroof 1 million. You will donate also like Okulate 500,000. Ogun will donate money too. And all of you, Majid, you are the coordinator. I am praying for you because Agbado biti ma ń gbó adàfin àṣẹ ni o. Amen. Okay, Amosu. Ta ló ni ẹ, Dr. Ogun?
This particular one, we talked about research in psychiatric hospital Yaba. And we talk about initiation. We talk about idea. We talk about having vision. And for this annual research fair in Federal Neuropsychiatric Hospital Yaba, we can't talk about it without remembering our origin, without remembering the initiator, without appreciating the brain behind this annual Yaba research. And this special award is a distinguished award for the initiator of Yaba Research Conference to Dr. Oluwayemi Cecilia Ogun.
Hello. Well, I'm also privileged again. Are you listening to me? Tinabaku aferu boju. Bodo Gerebaku Ashikino. Afamane Rokpo. I'm happy again today. You know, I don't know, maybe very soon I'm going to be, I'm celebrating my month in November. I'm a November Secretarian. And I'm happy that it is all happening during this season. Please, and you're ferry. And you're juicing me. You see, because you know why I'm saying it. You see, psychiatrists, there is no dull moment in psychiatry. And again, psychiatry is a way of life. Now, statistically, in those days, the highest rate of suicide is among psychiatrists, isn't it? Statistically in Europe. The highest rate of drug addiction is also among psychiatrists in those days. But in our own generation, we don't commit suicide anymore as psychiatrists. We don't use drug abuse anymore in this. We used to smoke cigarettes. Hello. In the 80s, early 80s, we used to smoke cigarettes here in Yaba. And we used to take alcohol, beer. You cannot open my fridge and you won't see beer or anymore. But Dr. Johnson cancelled it in 1982. That is the truth. Since that time, no more alcohol, no more cigarettes. Yaba is clean. But with that, we thank God that we will not commit suicide. We will always be prosperous. Dr. Ogu, I'm happy for you. You finish your tenureship gracefully, and God has blessed you. Your children will be okay in wherever they are. Now, what we actually initiated is an improvement of previous work that has been done by the founding fathers. We remember late Dr. Orija. We remember late Dr. Malomo, our mama, Dr. Mrs. Betta Johnson. In our lifetime, you and I, we will live long. Amen. We will achieve many more accolades. Amen. But today, it is your day. Please collect it. In the name of the Father, and Son, and also the Holy Spirit. Amen. Please, address us.
Thank you very much, sir. Yes, congratulations. It's a great pleasure receiving this today. And I thank God Almighty. I thank my teachers. They are here. Even though Professor Adeneko did not directly teach me, he was a friend to my teachers, and as well as Dr. Ladapo and Dr. Lawal. Myself and Dr. Lawal, we had our offices downstairs there. And I'm very, very happy again for the child and adolescent group that actually got the best. Don't look at me. Don't look at me. No, for the best results for this year. I thank God for that. I would like to say something, and I thank Professor Adeneko for this seed money that we have given research. Thank you so much. Okay, lọ́wọ́ afúnni gbé, okay, lọ́wọ́ yín ó máa gbé o. And for Dr. Okulate, who is not here, he has been a strong support of this research group. And can we give him a round of applause? History of research started with Mama Johnson. No? I would not know about Baba Mariho, but at least from the little that Auntie Shade, our Miss Jinodu used to say, when they used to go to Ajegunle for good boys and girls group, that they, even though they were not writing anything down, the research was there to stop drug abuse among children, secondary school students in Ajegunle. Miss Jinodu used to tell me. And then we will go all, I just came in when Mama Johnson left. Baba Orija too did his own bit. And Dr. Malomo for this research group was the one who initiated it, as well as the psychotherapy group. Research on Fridays, psychotherapy on Thursdays. And I do remember one time when Miss Jinodu locked Dr. Maloma out. Yes, it's as, and then when we say, Mama, you should be, they say, yes, psychotherapy should be one for one whatever. So, but Dr. Maloma took it in his own stride and said, yes, that is how it should be. That was the type of things we were living through in those days. And then Dr. Ladapo too continued. It was him as the head of clinical services that we started child and adolescent psychiatry in the room over there. So things have continued to grow in Yaba, and may we continue to grow. May we all continue to be inspired. Now, when I was living in 2027, I made a promise. 2022. 2021, sorry. 2017 to 2021. I made a promise, but then it wasn't taken up. I said, and I'm saying this, Dr. Jarogbe is here, Dr. Bello Mojidi is here, but when things were not really going as it, I told them then at the Child and Adolescent Center that I was going to be contributing 200,000 every year to child and adolescent mental health research. We have not taken it up. So I'm promising this year, I'm promising that for Child and Adolescent Center, for this year, I will be contributing 200,000 every year. So thank you very much, everybody. I thank you for everything.
Thank you, ma. Thank you.
Thank you very much. I appreciate you all.
Before you go, sir, we want all the panelists, the judges, to come and take pictures with you. All the panelists, please. All the panelists.
Panelists, Emabo.
All the panelists.
Everybody cannot be on one side.
You need to cover everybody. Thank you, everyone. Thank you, sirs. Thank you, Maz. Well, this is vote of thanks. Well, I've been thanking everyone, and this is to appreciate God Almighty and to thank our teachers and everyone, our trainers, our colleagues, our friends, our co-staff, and everybody in Federal Neuropsychiatric Hospital Yaba, and sister organizations within and outside the country. We appreciate the good messages from the Mental Health Desk Officer, Lagos State. We appreciate National Mental Health Desk Coordinator, Association of Psychiatrists in Nigeria. All our teachers are joined online across the country. Our NMA chairman, Lagos State, since he arrived till now, I said he cannot go. Thank you so